So, if one was wanting the highest possible effect and wanting to get it from day one because of a very high risk patient and wanting to get it early because, as we shared together, earlier reduction is much better, and wanting to avoid patient inertia, that might make you think about starting with a combo, with a statin plus ezetimibe. And you have to look at both the baseline LDL cholesterol and the percent reduction, and look at the relative risk reduction and the baseline risk, and then you get the absolute risk reduction. You have to look at see where your patient is in this table. It looks like a complicated table, but it's actually easy to pinpoint your patient based on the risk and the risk on the left here, and the untreated LDL levels in the horizontal bar. So many started saying, is it time for starting a single pill combination in dyslipidemia? We're not talking about low-risk patients or patients in whom you have soft targets. We're talking about patients in which you need higher intensity treatment, higher risk patients. And indeed, single pill combinations, when studied, provided a strategic approach that supports the intensification without increasing the pill burden, especially on people who don't want to take pills, or it also doesn't give the patients the perception that the treatment has failed them out and that the condition is really difficult and they need, they get scared. Oh my God, what's wrong with me? I need more pills. So SPCs have been shown to increase adherence to lipid-lowering treatment and success of your patients reaching the LDL goal. And we know now that the goals have moved. So this is the new cardiovascular risk categories. And patients on this slide will already documented atherosclerotic cardiovascular disease, either in events or subclinical atherosclerosis, but significant, or diabetic patients with higher risk, or CKD patients, or patients at high risk. All those, and then you get the high risk and the moderate risk and the low risk. And that's their target. So for the very high risk, you need the LDL to be below 55. For the high risk, below 70. For the moderate risk, below 100. And for the low risk, below 115. So pretty difficult targets to reach, especially if you're starting with a high baseline. And it was looked at recently in 2022. There was a study on the long-term efficacy and safety of moderate intensity statin with ezetimibe combo versus high intensity monotherapy in a randomized open-label non-inferiority trial. And guess what? Among patients with atherosclerotic cardiovascular disease, the moderate intensity statin with ezetimibe was non-inferior to the high intensity statin monotherapy for the 3-year composite outcome, with a higher proportion of patients reaching the target and a lower proportion of patients discontinuing the drug side effects, whether real or perceived. Okay? Whether real or perceived. Because if they have a perceived muscle pain, which is not real, and they stop the treatment, they still stop the treatment. You can sit and argue all day long. At the end, the patient decides. So we know from studies like this that starting with a combo, and we also, the majority of the statin LDL efficacy is actually at the starting dose. So if look at this. If you give the patient 10 milligrams of atorvastatin, the majority of efficacy, 37%, then you get the 6% rule. Every time you increase the dose, you get a 6% reduction in LDL for any of the statins. That is why we believe that if you want to avoid all this up titration, moving from one dose to the other using the 6% rule, you can actually start with a moderate intensity statin ezetimibe or a high intensity statin ezetimibe, one-step co-administration. This has been studied, and more cardiologists are beginning to like it. And very recently, another look at the IMPROVE-IT in 2021 was done to look at the clinical outcomes of the combo. And again, adding ezetimibe to statin consistently reduced the risk for cardiovascular events in the highest risk patients, which are the post-ACS patients, irrespective of the baseline LDL values, supporting the use of intensive lipid lowering with the combo, even in patients whose LDL is below 70. So this is a new look at the IMPROVE-IT, and this was in the popular press that ezetimibe plus statin therapy actually reduces post-ACS cardiovascular event risk. And this is my last three slides. This was an important paper from in February 22 by Kausi Cray and his colleagues saying combo lipid lowering as a first-line strategy in very high-risk patients. So we don't have, you can up-titrate and you can take your time in low-risk patients. And in very high-risk patients, you want to reach the target early. And indeed, this algorithm was proposed that the combining a lipid-lowering therapy as first-line strategy in very high-risk patients, you can start in very high-risk cardiovascular risk with statin ezetimibe, and in extreme risk, you can even start with a PCSK9. And if you don't get the reduction in this group, you add the PCSK9 and so on. So starting with additional non-statin treatment like ezetimibe or even PCSK9 sometimes makes sense. And of course, economically, it makes a lot of sense to start with statin ezetimibe because, as we know, PCSK9 injectables are expensive. This is my last slide. But even though the current guidelines recommend up-titration of treatment to target with statins, there's an accumulating wealth of new evidence that starting with statin ezetimibe combo may be more effective in lowering LDL even at a moderate statin dose than the maximum statin alone, and more well-tolerated. And more importantly, there is a recent study showing that this combo reduces clinical MACE, a recent look at the IMPROVE-IT, in ACS, in post-ACS patients. So we think that it's not just a matter of tolerance and not just a matter, but it's a matter of reaching the target faster and reaching and more patients reaching the target and in reducing hard endpoints. So the combo pill early from the first attempt was suggested by leading societies, leading lipidologists to reach target as early, as quickly, as safely as possible in high-risk patients. And of course, the effects of the single pill combination in compliance and adherence are well proven in many studies. And it is something which we're probably going to be seen in many guidelines soon. Thank you very much. And again, I thank the organizers and I thank you all for being here.
Dr. Hani, we don't receive yet any questions, but do you mind to give us maybe a summary of like one minute of your take-home message for starting the combination therapy or the combination pill as you describe it?
Thank you very much. Yes, and I'm very sorry. I hope the slides were clear at least. The point is that now with the change in the targets to include many different risk categories and some of the patients who don't seem to be at high risk, for instance, diabetics who have been diabetic for 25 years or patients who find 60% carotid stenosis asymptomatic on a duplex, all those patients have to go down to targets of below 55, which also includes about 1 in 250 of all humans who have heterozygous familial hypercholesterolemia. It's estimated that the number of people with an LDL of above 190 in healthy people who are walking around is about 120, is 1 in 250. All those people are unlikely to reach the targets with the first low dose of statin. So if people give them, like 10 milligrams of whatever, and then retest them in 6 weeks and find that they haven't reached the target, so they give them the highest possible dose of this particular statin, and then retest them again in 6 weeks, and either find that they have reached the target or they haven't reached the target, and then they change. We face two problems here. The first problem is a patient-related problem, which is that the patients might not do very well with this sequential raising of the dose. It scares them. It gives them an impression that the condition is more difficult to treat. It's obviously better for the patients because patients see their numbers and they get told. It's obviously better for the patients to reach their target treatment from the first attempt. They will feel that they're even being treated by a better doctor, especially in private. So, and the other option is in physician inertia or in patients who live away, who simply take the first pill and they leave and they think they have a treatment for the cholesterol, and then they're not really followed up or not up titrated. So our point, many of us, in those high-risk patients, we suggest, based on the current data, which shows that it's safe and effective and more event reducing, to start with a combo pill with moderate intensity statins and ezetimibe, and even in the highest risk patients who have an LDL of 200 plus, even with a high intensity statin and ezetimibe combo pill. And that way, you will get rid of so many problems at no penalty. No penalty, unless in your own community there's a major difference in cost issues. But for instance, where I practice, there's no penalty in starting with no penalty for the patient, no penalty for the doctor, no penalty for the system, all advantages. And it's not really outside the guidelines. The guidelines do recommend it as a second step, and we know that the majority of such high-risk patients will need the second step. That was the summary of my presentation.
Thank you, Dr. Hani. There's we have maybe another 2 minutes. There's a question regarding this combination therapy, and are we expecting more muscle pain, more myalgia, and so in this case, what should we do? Should we break the combination therapy, because we don't know with this combination, is it the statin, is it the ezetimibe? So what's your
thank you very much. Yeah, I can read the question. Actually, ezetimibe has not been reported to cause any muscle pains, and we do know that the majority of muscle pains on statins are not actually caused by the statin as well, but that is not something that patients believe. So if a patient comes with muscle pains, in my practice, I discuss with the patients and I assess the risk. And in the worst case scenario, I'll go down to the lowest combination of the lowest dose of statin. So for instance, if I'm using an atorvastatin ezetimibe combination, instead of 80 with 10 or 40 with 10, I'll go down to 10-10. And many of the patients still stay on target. And then we can up titrate gently if they haven't. And the same with Grosuva. I'll go down to 5-10. So, obviously, if the patient is totally intolerant regarding muscle pains, and if the patient knows that they're in a high-risk group and that this is a life-saving drug, but still says, no, I don't want to take it, that's the true statin intolerance, whether it's physical or psychological. Because a truly psychologically patient who will just not take statins, even if you believe as a physician that they're imagining them symptoms, which is the worst case scenario, you still have to comply with the patient's wishes. So of course, there are the true statin intolerance. In all cases, we now have the injectable drugs, we now have the PCSK9, and we now have the inclisiran, which such a patient can take an injection every 6 months and do really well. But yes, we will actually, especially if we have objective evidence like a high CK, we will actually reduce the dose of statins and rely on a combo. And with this kind of combo, you're more likely to reach the target with a lower statin dose, as the last paper I showed in my presentation pointed out.
Great. Thank you very much, Dr. Hani, for highlighting this topic and all this issue. And I hope you will stay with us to listen to the next speaker. So now it will give me the pleasure really to introduce Dr. Walid Al-Dhahi. Dr. Walid Al-Dhahi, he's the head of Kuwait Diabetes Society, and he's a consultant in endocrinology and diabetes at Mubarak Al-Kabir Hospital. And he's also a visitor consultant in endocrinology and diabetes at Kuwait Oil Company Hospital. So Dr. Walid will present the other side of lipid management, which is, we see it in most of the guidelines, either the international or local even, so which is the stepwise starting of lipid treatment in managing of these patients with high atherosclerotic cardiovascular disease. Dr. Walid, the floor is yours.
السلام عليكم. مساء الخير جميعا. Thank you, Mr. Chairman, for your kind introduction, and thank Organon for involving me in this interesting talk about platelets, and thank Dr. Hani for your great lecture. I'm just gonna start to okay. So my job is to talk about what's written in the guidelines about. I hope you're hearing me.
We hear you very well. Do you manage to play the slides?
Yes. Do you see my slides?
Yeah, we see you. We see it. Yeah.
Yes.
We see the first slide.
Thank you. So when we talk about cardiovascular disease, this is just to show you that cardiovascular disease is one of the most important diseases that happens in the world, and also in our area. In the Gulf, we are in the top 10 causes of death is cardiovascular disease. So we are suffering from cardiovascular disease and dyslipidemia. And unfortunately, we have high unmet needs, especially people who are at high risk. And you can see here that people who have recurrent cardiovascular events are more severe and costly compared with the people with the first events. And the people who already have event before, their survival rate, their cost is very high compared to people who have the first events. And also, nearly 1 in 5 post-MI patients will have recurrent events. So this is a disease that is staying with us, as Professor Hani was saying. This is a very aggressive disease, the cardiovascular disease, and we see that every day in our area. When you look at the real-world evidence, the real-world evidence is actually shows even more, prevalence of, MACE rates comparing to what we see in the randomized trial. So this is just to show you how big is the problem that we are facing. Now, LDL is the focus of our treatment, and we know that for many years people are actually still even in the Gulf, some doctors were saying that cholesterol is not important and all of this that have no evidence. But now we know that LDL is our major risk factor, and it's our major target in management of cardiovascular disease. So this is just to show you how important LDL is. Now, if you look at the trials over the years, using different modalities, we know that the lower the LDL, the better overall for our patients, and this is proven by different modalities and different randomized trials. And over the years, we know that even the guidelines have been lowering LDL because of the availability of evidence, and also because of the availability of medicine that can lower LDL to a safe target, as you can see here. So we still are waiting for more even evidence to manage this kind of LDL and also other lipid modalities. And LDL is correlated very well with reduction in cardiovascular disease, and this is clearly shown and clearly proven with each millimole of 39 milligram reduction in LDL over 5 years. There's association of a greater risk, around 23 risk reduction in major coronary disease and 21 risk reduction in major vascular events. So this is just an introduction to show you how important is the LDL with the cardiovascular disease, and over the years the guidelines actually translating this information, as you can see here, from 1985 till around 2020-21. The guidelines is also translating this importance. Now, when you talk about failure of optimizing LDL, as Dr. Hani was saying, there are many causes that actually lead that we are not reaching LDL. Not only of failure of medicine, and this is basically the idea that because many patients, they come with have failure in their lifestyle, failure in adherence to medication, and also we have lots of genetic invariability in response to treatment, inability to tolerate the optimal therapy, and this is also one of the big issues. But when we look at insufficient control with with the maximum dose of lipid-lowering therapy is actually one of different causes. But most of the time, the doctor's just attacking that the drug is not working, let's go to another drug. And that's the reason why sometimes even with the combination therapy, we don't reach actually our goal because the patient is not opting a lifestyle that actually translates better with his general condition. And also some doctors are not basically adjusting the doses according to the patient needs. So there are several factors, not only failure of medication. This is one of the what we call the physician inertia. And this is a very interesting study. It's a very old study in 2000, but I always like to use it in my slides. And this is basically where they went to the physicians and they asked them about the awareness of the guidelines. And you can see here 95% are aware of the guidelines, but when they open their files, actually only 18% they translate the guidelines into their action. So provider awareness does not equal successful implementation. And this is one of the big issues we are facing in the management of dyslipidemia and also other diseases like diabetes and the others. And this is basically where the focus of most of the guidelines, where you don't only think that there is failure of medication, there are other reasons you have to think about when you manage dyslipidemia. Now, when you look at the guidelines, recommendations, and advice about lowering LDL based on cardiovascular disease, we know that there is very high risk and high risk, and that the guidelines have been little bit changing over the years by definitions of what is high risk and what is very high risk. I'm sure you all know this. I don't have to read it for you, but in the guidelines, statins are universally recommended as a first-line therapy across the whole guidelines, followed by ezetimibe and then PCSK9. So this is basically what most of the guidelines said. So stepwise approach is the focus of all the guidelines we have. ESC, American College of Cardiology, American Heart Association, AACE, ADA, all of them, they insist on stepwise approach. And that's not because this is just basically a coincidence. No, it's because the evidence we have is basically support this. We don't have good evidence, although there are small studies, and Dr. Hani mentioned some of them, but there is no good randomized evidence saying that when you give multiple medications at the start, it's a logic, but doesn't really prove. And in medicine, we don't go with logic, we go with the proof. That's why the whole guidelines, they go with the same idea, stepwise approach in the management of dyslipidemia. Let's go by one. And this is in 2013. The guidelines said a stepwise treatment intensification approach aiming at intensive risk factor treatment. So it's not only lipids, it's risk factor treatment. And the problem when managing dyslipidemia is that we focus on the medicine and we forget the other risk factor modification. And then when something happens, we say there's a failure of statin. No, it's because you have to manage the whole risk together. And if you put all your weight on medication and you forget about the other risk factor, this is not a proper management. That's why the guideline is saying you have to put things all together. Now let's move from 2013 to 16 and 19. You can see here that always start with a statin, and then if not tolerated or the high dose is reached, then you go on 2016. They said ezetimibe, PCSK9 may be considered. And then in 2019, they said after 4 to 6 weeks with maximal tolerated statin therapy and ezetimibe, adding PCSK9 is recommended. And the reason is because between 16 and 19, there is more evidence about PCSK9 and ezetimibe. That's why in 16 it was May, and then now it is basically a fact that we can use. And that's why we have this kind of segregation of our patients according to their risk and according to their need of aggressiveness. I do agree with Dr. Hani that as a very high risk, we tend to need to be more aggressive, but that's why the guidelines is basically based on evidence that had to put people into different groups so they can actually manage and reach the level of LDL. Not everybody needs an LDL of 1.4, and that's probably one of the misleading ideas that the doctors are using. I have all these medications, let's push my patient to to 1.4, and the patient doesn't need that because he's not in this group of risk. So this is basically why the guidelines is very clear. This is the guidelines from ESC, AAS, you can see this is just a scream of the guideline, and ezetimibe is added after the use of statin. Let's go closely, and this is basically the guideline. Total cardiovascular assessment, baseline LDL, indication for drug therapy, then you go for, if you need to go for therapy, you'd use high potency statin at high recommended tolerated rate, or you can, if they have low risk, you can go with lifestyle modification, and then you add ezetimibe. If the LDL goal reached, then you follow up annually. If not reached, then you go with PCSK9. So the guidelines is very clear in this. And this is basically, we move now to 2018, American Heart Association, and you can see here that again, statin therapy should be initiated or continued with the aim of achieving 50% target. There is no mentioning of early combination therapy. And then for people with less risk, you can use moderate intensity statin. Again, this is secondary, that was primary prevention. This is secondary prevention. You should include maximum tolerated statin and ezetimibe. So basically, this is also a move with a more aggressiveness. You still have to have the stepwise approach, as you can see here. Again, this is the 2018 guidelines. This is the primary prevention. I'm not going to read it, but just to show you that you have to do more risk stratification, and then you start, statin with lifestyle, and then you add ezetimibe as it's needed, and then PCSK9. This is secondary prevention. Again, the same thing. There is no mentioning of starting very early combination therapy. This is the 2021 ESC guidelines on cardiovascular disease and clinical practice. This is recently published, and this is from the guidelines, and there what they say, stepwise approach to individualize the cardiovascular prevention, and the rest you all know. Using the SCORE, age specific risk atherosclerosis is in healthy patients, estimating lifestyle cardiovascular is all of this. But what they said in their guidelines 2021 is stepwise approach, as you can see. Again, this is from the guidelines. It is recommended that the high intensity statin is prescribed up to the highest tolerable dose to reach LDL. And as Dr. Hani said, most of the side effects of statins is basically not related to statins. So many doctors, they just shy from giving the high dose because what they said, no, this is all because of the statin. And they don't do the effort of thinking about, manipulating the dose, thinking about other causes that may cause side effects, as we all know. For secondary prevention, patient not achieving their goal, maximum tolerated dose. So this is basically the stepwise approach is emphasized in 2021, and then you add ezetimibe and combination therapy and PCSK9. Let's look at the American Diabetes Association, the 2021 standard of care medical practice. Let's see what they say. For patients of all ages and diabetes, atherosclerosis, cardiovascular disease, high intensity statin therapy should be added to lifestyle modification. So then in the second line, you can see adding ezetimibe and PCSK9 may be preferred. PCSK9 because of the causes may be preferred. So ezetimibe. So basically in the ADA, they still concur on the stepwise, concur on managing statin with high dose, and then use ezetimibe as a second line, and then PCSK9. The AACE, which is basically 2020, this is consensus treatment of the American Association of Clinical Endocrinology, and you can see this is from their guidelines, and you can see they put them at extreme risk, very high risk, modest risk, and low risk, and the lipid management. And you can see here lifestyle high intensity statin is basically the starting modality in the management of dyslipidemia. And then if you don't reach, you add either PCSK9 or ezetimibe, as you can see here. So basically this is something that is concurred in all the guidelines that you have to do the stepwise. So stepwise approach based on guidelines, all the guidelines adopt the same idea of stepwise approach. And this is because it's more practical, it's cheaper, it's based on evidence, and also give opportunity for doctors to use the medication in the proper way and not to jump to another class without the need. So risk stratification is step one, very important. And this is one of the major flaws in our system. We see in our doctors that they put everybody in the same basket, and then they say everybody needs to take PCSK9. This is wrong, and this happens in Kuwait too. We have very heavy movement to use of PCSK9 without indication, because of this aggressiveness idea. Every doctor is now pushing to be more aggressive. They say, I'm going to save my patient without looking at the category. Lifestyle and statin is going to be a step 2, which is very most important step in the management of dyslipidemia. Add ezetimibe, add PCSK9, and then meet LDL and non-HDL goals to achieve atherosclerosis risk reduction. So this is basically all guidelines concur on the same idea, as you can see here. So LDL reduction, it is difficult. We know that 75% of patients with atherosclerosis did not achieve target and LDL, as Dr. Hani also mentioned, similar idea. But this is telling us not to go more aggressive, to go more actually wise and use our medications in the proper doses. We fight inertia, we advise lifestyle modification, and then we move to the other class. And this is where we have to manage our patient. It's not only lipid modification. Lifestyle, blood pressure, glucose monitoring, all of these actually will lead to cardiovascular disease. So it's not only putting your all emphasis on lipid modification, you have to think about your patient in a more thorough fashion. Now, the ticking clock hypothesis, which basically happens to most of our patients with micro and macrovascular disease with diabetes, you can see that macrovascular disease starts even before the diagnosis of hyperglycemia. So more meds, more cost, more side effects does not really help if you actually don't start very early in the treatment. So managing our patient very early, identifying the patient that need to be managed at high risk very early in their journey in this disease is more important than pushing more medications to the patient. So in summary, LDL is the main target. Failure to achieve target is multifactorial. It's not only failure of medications. Stepwise approach is persistent in all guidelines. Early combination therapy could lack evidence. We don't have big evidence. More expensive. Probably can also add more side effects. So we have to be wise and use it in particular, as Dr. Hani was saying, maybe some particular patients we need to be very aggressive, but most of the dyslipidemic patients, they don't need to be aggressive in the start. Thank you very much.
Thank you very much, Dr. Walid, for this comprehensive review of the evidence for the stepwise using of lipid lowering in the management of patients with high risk. I'm still waiting for questions to come through the chatting icon. Till that time, maybe I can ask Dr. Walid. So you beautifully thought about the stepwise, and how about if we from the beginning that we know that these patients are really at very high risk, and like you beautifully had summarized, the different studies showing, we are aggressively going lower and lower with the LDL cholesterol target. So for patients with MI and another MI within 2 years, they propose that you go even to at least 1 millimole or around 44. So starting, even with high intensity statin in this patient, we know, from the observational study that usually they it's very, very difficult really to bring them to that low. So in this case, I mean, will that change the view that we need maybe another combination therapy? I mean, in those only special patient?
Yes.
What do you think?
I do agree, and I agree with Professor Hani few last slides, where the very extreme high risk patient, probably you need to be more aggressive at start. And still we don't have evidence for that, but logically, and there are some papers going out here and there that showed that probably it's much better, compliance is better, and reaching target is faster. But the issue here, we're not talking about these few patients out of the whole dyslipidemic population. And unfortunately, these facts has been translating to all patients with dyslipidemia. And they said, what are you losing? Be aggressive. But my question is, if I have a patient who's the moderate or very high risk, not very extreme risk, and he don't have to cover his hypertension and his diabetes and his proteinuria, and I just want to push more lipid management, does that really does the evidence help you to do that? It actually goes against you. So the idea here is that you have to use these medications wisely because of the expensive nature, and also because there's no evidence that you can if you use them earlier. You lower LDL. We have for many years. The most famous example is digoxin with the DITCH trial, 7 years follow-up. Everybody احنا نقول يحلف براس digoxin that it will improve heart disease, but at the end it's just symptomatic. It does not really improve mortality after the trial. So we are here as scientists. We need evidence, and also we are smart enough to use the evidence available to help our patients. But my idea is not going against Dr. Hani. Of course, I totally agree with Professor Hani, but we don't have to put this for everybody. And that's the problem. Even in Kuwait, for example, where PCSK9 are giving free of charge for locals, now everybody is on PCSK9. Is that really what we want to do?
Yeah, great. So, beautiful answer. So, do you think then maybe implementing what we call a risk stratification in patient with secondary prevention, or those patients with extreme risk, will help to guide at least where we should put our money, like you say, because it is a cost at the end. So we should put our money, especially in those patients from the beginning, from policy make a decision. So do you think that will be useful?
Yes, I totally agree. I think especially in countries where there is a system and patient is followed, and there is online services where actually patient, once he seen by cardiologist in the CCU or ICU, he should be labeled with a level of risk, and based on that, is basically everybody will follow. Here we're talking about public services where the service is given for free, and you cannot manage a free service by loose ends. You have to be very tight because you want to help many people. And we are in the MENA region, and I'm president of Kuwait Diabetes Society. We meet a lot with the MENA region. We have in our colleagues in our neighbor countries, they have even difficulty in taking enough doses of statin itself, rather than use of ezetimibe and PCSK9. PCSK9 in some countries like a dream. So risk assessment is very important. Using your tools is like, you are in a war and you have limited, forces, and you have to use your forces in the right places. So if I have very extreme risk, I will give him, but if I have somebody with low risk, I don't have to give him. And that's happened in Kuwait. We have PCSK9. We've been using it. It's been open a little bit more. People are now giving it to everybody. Now we don't have PCSK9 because the drug is not available, and now people who need it, they don't have it.
Thank you very much, Dr. Walid. I think we can conclude here. I would like really to thank both Dr. Hani and Dr. Waleed for this excellent debate, and it was really very nice to exchange thoughts and the ideas, and I hope that the participant side had taken the message that really the use of the combination therapy is really needed, but you need to look for the right cohort of patients, especially those with very high risk or extreme risk, for more cost benefit of this treatment. So with that, I think we will end. Michael, over to you if you want to.
Yeah. So thank you so much, Professor Khaled, Professor Waleed, and Professor Hani. This was really interesting to see the different opinions, different points of view. And as you said, it's like a spectrum of patients, and you can allocate your treatment according to the type of the risk or according to the patient profile. And as you said, like it's again a complementary points of view, not just like either or. It's like both can be applied in different scenarios. And this is what's really great. And now we're blessed to have like this whole spectrum of armamentarium of lipid lowering drugs that can suit different patient profiles, starting from the low risk or until like the extremely high risk patients. So the clear message is that we can get patients to target, of course, as long as you know the tools and you know where they want to go. So on behalf of myself and the whole Organon team, we want to thank Dr. Khaled, Dr. Waleed, and Dr. Hani for your valuable contributions. We want to thank all the online audience for your presence, for your interaction and your participation. And we will move now into the third session in our dyslipidemia track, which is talking about women and cardiovascular disease. So for those who are attending online, stay with us, don't go away. And we will see you again in a couple of minutes for the next session. Thank you so much and have a good rest of the day.
Thank you very much. Thank you, Dr. Hani, Dr. Waleed. Thank you very much. Thank you.
Thank you very much. Goodbye.
Bye-bye. Thank you everyone for joining. My name is Michael Sadiq. I'm a medical advisor from Organon Egypt, and I would like to welcome you all for the third session in our cardiovascular program today, which is called Saving Women's Hearts, a Cardiovascular Disease Dialogue about the Cardiovascular Disease in Women. So again, as Organon, as a company dedicated to saving and improving women's lives and providing a better and healthier every day for every woman, one of the really important issues for us to talk about is the women in each therapy area. And of course, cardiovascular disease is one of those most important areas. So today we're talking for the first time in Organon about the women and cardiovascular disease. And to start with that kind of dialogue, of course, we have two eminent professors with us to talk about the cardiovascular disease specificities in women and how we can close this gender gap. So we have with us today from UAE, Dr. Juwairiya Al-Ali. Dr. Juwairiya Al-Ali is the president of Emirates Cardiac Society and a consultant cardiologist in Rashid Hospital. And we have Dr. Nerina Okasha. Dr. Nerina Okasha is a professor of cardiology in Ain Shams University, Cairo, and she's a fellow of the American College of Cardiology. So today we're having a kind of an interesting dialogue with those two experts about cardiovascular disease in women. And we will start with the first question to Dr. Nerine. So Dr. Nerine, can you please share with us the recent data regarding the prevalence of cardiovascular diseases in women, and how does that impact the morbidity and mortality for women across the world?
All right. Thank you, Michael, for the introduction. I hope this session is going to just try to highlight the gap between males and females in cardiovascular disease and in the different lines of management. I'll start by sharing my screen right now. Okay. Now, can you see my screen?
Yes.
Yes, okay. Let's see. As we all know that cardiovascular disease is the #1 killer of men and women. The chronic heart disease, the MI, the acute coronary syndrome, accounts for more than 50% of the cardiovascular deaths, followed by stroke, heart failure, and high blood pressure. And this is both for men and women. It was once believed that women are immune to cardiovascular disease, but this has proven to be wrong. Let's see some facts about cardiovascular disease in women. Cardiovascular disease kills more women than all forms of cancer combined together. Among females at the age of 20 years or older, nearly 45% are living with some sort of cardiovascular disease. Cardiovascular disease is the #1 killer of the newborns and accounts for over 1/3 of the maternal mortality. Less than 50% of women entering pregnancy in the United States have good heart. This means that more than 50% are having a heart disease during their pregnancy. Premature heart disease versus premature cancer. While premature cancer death continues to decline, premature heart disease death increased after 2010. The mortality gap between premature cardiovascular disease and premature cancer is narrowing over years. Cardiovascular mortality in women on the rise again. They found that during the era of 1999 until 2011, the mortality from cardiovascular disease in women have declined by 23%. But unfortunately, and we don't know why this happened, but the mortality raised by 7% in 2017. Women have slightly lower incidence of cardiovascular disease than men, but if they have cardiovascular disease, they will have more mortality than men. 38% of women experience a heart attack will die within 1 year compared to only 25% of men. 35% of women with a heart attack survivor, they will have another heart attack during the first year compared to 18% of men. Women have, they have bypass surgery, they will die twice as much as men. Okay.
So thank you so much, Dr. Nareen. And again, this is kind of an eye-opener data showing us that there is a very big gender gap in the morbidity and mortality of cardiovascular diseases, which needs all of us to act together to address this issue. So Dr. Juwayriya, coming to these gaps, can you please describe in more details the current gaps and the treatment disparities between men and women in cardiovascular disease?
Sure. I mean, the gaps in cardiovascular disease happen not only in the therapy, but also on the presentations. Women are more likely to have atypical chest pain or non-anginal pain, which makes them less likely to be recognized by a physician. And often, women in a younger age, because of the misconception that women are unlikely to have coronary artery disease, they're more likely to be unrecognized, and usually their presentation is more complex. So they usually present with an acute MI or heart failure or sudden death, which is different than the presentation for men. And generally, coronary angiogram in women doesn't show evidence of atherosclerotic coronary disease because the problem is in the microcirculation. So they often get dismissed by the physician because they think, well, the coronaries are normal, so this is not cardiac, but that's not true. And then, given that they have higher prevalence of cardiovascular risk factor, they're more likely to be excluded from trials. So women are underrepresented in the trials. And this is a major problem because since the cardiovascular risk in women is under-recognized, it's under-recognized both with physicians and with women themselves. So less than 50% of women knew that the #1 killer for them is cardiovascular disease. And usually women are embarrassed by the issue of cardiovascular disease because they think it's related to weight. So they think it's their problem. You know, they cause this to themselves, which is not true. There's lots of risk factors related to cardiovascular disease. And the other problem is cardiologists or general GPs, they are uncomfortable assessing cardiovascular risk in women. So that leads to disparities. So what disparities do we see? So we have seen disparities in the Gulf countries. So this study looked at patients with high risk and very high risk atherosclerotic cardiovascular disease and whether they achieved their targets. So in this study, average age was 57, which of course younger than the age in the Western population, and 40% of patients were women. So that's a good representation of women. And we saw that women were more likely to be diabetics and more likely to have metabolic syndrome compared to men. Also, women were less likely to achieve their LDL target or HDL target or ApoB target compared to men. And this gap was even higher in women with a very high ASCVD risk score. So they were even more unlikely to achieve their targets of LDL or non-HDL cholesterol or ApoB. And this is similar to what we see in the Western countries. So this is the Sweden registry, a Sweden Heart Registry, which looked at patients who had a presentation of acute MI within the past year. And they found out that women were less likely to achieve their LDL targets compared to men. Also, they were less likely to achieve their blood pressure target compared to men. We saw the same thing in the Virgo study analysis. So younger women with MI had higher risk of cardiovascular risk factors. They have higher rates of depression and stress and poor physical status overall. And they usually present late with a higher risk score. So their presentation of acute MI is of higher risk, and they are less likely to undergo revascularization, which is a major problem because we understand that revascularization, time is myocardium. So if you don't undergo revascularization, you're losing precious time and you're losing precious muscle, and women were less likely to achieve that. So if we look at this population-based study in Spain, women who presented with acute coronary syndrome, so these are patients who are identified as acute coronary syndromes, they're less likely to receive all the therapies that we know that are good for the heart. So less likely to receive aspirin, less likely to receive P2Y12 inhibitors, oral anticoagulants, ACE inhibitor or ARBs, beta blockers, and statin. And the same was found in the Sweden Heart Registry as well. Women were less likely to receive all of these therapies, and they were less likely to receive reperfusion therapy as well. The only thing that favored women were more likely to receive nitrate, which we all know nitrate has no mortality benefit. It was only symptomatic therapy. So, and there is also a 6 difference in the pattern of prescription of a statin. So this is from the United States, looking at patients who presented with acute MI between the year 2007 and 2015. And we see that women were less likely to be initiated on statin and were less likely to have low to moderate intensity statin. There was some difference in high intensity statin, maybe not statistically significant, but it was less in women than men. So these are the discrepancies that we find between the treatment of women and men. So I'll hand it back to you, Michael.
Thank you so much, Dr. Juwairiya. And as we dig deeper into this topic, we see the gap in different aspects, like in different areas of cardiovascular disease. And that brings us to the next topic, which is the risk factors. So, Dr. Nerine, we want to examine closely and to understand, do women have specific different risk factors than men? I mean, like we have the traditional risk factors, and nowadays there is an ongoing talk and debate about the non-traditional risk factors specific for women. So can you please give us more data into this topic?
Okay. Just a minute. Okay. خليني ألخص القصة بتاعتنا هتمشي ازاي. Now we have the common risk factors. Common risk factors are the risk factors for cardiovascular disease in both men as well as women. We all know about them as the age, hypertension, hyperlipidemia, smoking, diabetes, high density lipoprotein, sedentary life, obesity. All those are the risk factors for most of them. But do these risk factors act exactly the same for women as men? And then we will target the woman-specific factors that they males doesn't have the same risk factors. Let's start by the general risk factors for both of them. I'm just going to tell you some facts about the situation in the different risk factors. Let's take smoking. We know that smoking is one of the very strong risk factors for coronary artery disease. When a woman quits smoking by the age of 39, she will add 3 years to her life. But when a man quits smoking at the age of 39, he will add 5 years to his life. Smoking in females, in women, have a greater negative effect on the HDL than in men. Smoking has more influence on developing coronary artery disease in females than in men. Meaning that if a male and a female, they are both smoking at the same age for the same period of time, say for 5 or 10 years, the woman will have more chance to have acute coronary syndrome than the men of the same age and of being smoking the same amount of cigarettes for the same time. Again, the high blood pressure. High blood pressure is the leading cause of stroke in men and women. Women have more severe symptoms than men with similar blood pressure over the same amount of time. The hypertension is 2 to 3 times more common in women taking oral contraceptive pills than those who doesn't take. And it is more evident in those who are taking contraceptive pills while they are of an age more than 35 years or they are obese. Hypertension has a higher mortality rate in women than in men. Hypertension leads to more heart failure in women than in men at the same level of blood pressure and with the same medication. Again, let's see the epidemiology of cholesterol, which is a very potent risk factor, the hyperlipidemia in women. According to the National and Nutritional Examination Survey data representing the risk factor, the total cholesterol in women from the period from 2015 to 2018, they found that more than 40% of women having total cholesterol level of more than 200. More than this, 12% are having a total cholesterol of more than 240. Those are completely asymptomatic women. They are the normal women in the normal population. 8% of these women having a high density lipoprotein, which is the protective lipoprotein less than 40. They have more than 30% of them are having an LDL over than 130 milligram per deciliter. The women and men, they tend to have the same level of total cholesterol till the age of 35. And then there is gender discrepancy between both of them. As the advance in age, the women are having more tendency to have higher cholesterol level than the males. With familial hypercholesterolemia, things are different. We used to say that females are having the protection of estrogen till the age of menopause, so they are protected, so that's why the cardiovascular disease appears more in male at this age. And then after menopause, both women and men will have the same incidence of cardiovascular disease. This is totally different in those with familial hypercholesterolemia. If a woman is having a familial hypercholesterolemia, either heterozygous or homozygous, they will lose the protective effect of the female hormones. They will tend to have premature coronary artery disease, and they will have it at the same age of the men. Let's now see the woman-specific or the female-specific risk factors, which are risk factors related to the reproductive system and the reproductive hormones. Pichler et al. 2018 found each of the following to increase the risk of cardiovascular disease in the UK Biobank study population: early age of menarche, early menopause, history of hysterectomy, and among those who gave birth, early age of first birth, or history of miscarriage or history of stillbirth, all those have a higher incidence of developing premature or early cardiovascular disease than those who haven't. And if we try to summarize this, we will find that at the age of childhood, those girls who have early age of menarche or late age of menarche, they are more cardiovascular disease late in life. Again, those with polycystic ovary syndrome, or with infertility, or those who got pregnant and had an adverse outcome of the pregnancy, like toxemia or hypoxemia, or eclampsia, or they have hypertensive disorder, or they have premature preterm deliveries, they are more at more risk of developing cardiovascular disease. Again, the late reproductivity, which is meaning that they had their first baby after the age of 40, they have more incidence of having cardiovascular disease than those who had their first baby earlier in life. Again, lack of breastfeeding. Again, after they develop menopause, they have also risk factors. Those who have early age of menopause, those who have surgical menopause, meaning that they removed their ovaries or their reproductive system early in life due to any disease, or those who have vasomotor symptom severity, those will have more evidence of having cardiovascular disease than others. Again, the cardiovascular disease and the female disadvantage. We discussed the risk factors, and we knew how the risk factors will affect women in a totally different way than in men. Again, there are other factors which is related to the disparities in the cardiovascular disease in both men and women. One of them is related either to the lady herself, and the other thing is that related to us as physicians. So let's see what's the personal factors. If I just said now the ladies got the feeling that they are to be responsible for their heart disease, maybe because of their obesity, maybe because of what they did wrong or something like that. They don't tend to admit that they have a cardiovascular disease, and they don't seek medical advice. They have most of the ladies, they have false optimism, as well as the GPs and the cardiologists. They have false optimism regarding the degree of protection of cardiovascular disease due to the estrogen. Women may be unsure of the issue regarding their cardiovascular health. Maybe they have different symptoms. They just don't say they think that this is normal. Women may be more likely to put their families first and compromise their own health. Usually when we see a female coming to a cardiologist, not to the GP or to the internal medicine, when she finally reached the cardiologist, she already has progressive coronary artery disease, because they tend to think that this is normal, maybe because she is tired, maybe she worked too much, maybe she has a lot of physical things at home that she is responsible for her symptoms, but they don't believe that this may be a really heart disease. About professional healthcare factors that we are lagging, and we need to increase the awareness about it. We as medical practitioners are prone to the misconception that cardiovascular disease is being a predominantly male problem. Cardiologists are less likely to rate usefulness of the angiography in a female as high. So usually when we have a male and a female, a woman and a man, both of them are coming to the clinic, and both of them are having the same complaint, or both of them they had a test done. Both of them are positive. We are probably to say, there is a very high incidence of false positive stress test for the female. She is 30, 35. She is not. She's having a menstruation. Maybe she is protected. I will not do any further. I will just give some medical treatment, and I will follow her. If the same scenario with a male patient came to your clinic with a positive stress test, on the second day you are going to perform a coronary angiography. And this leads to the late diagnosis of the coronary vascular disease in females, and that's why we are having more problems with females with already diagnosed cardiovascular disease, because we diagnose them a little bit late. The adjusted odd ratio for women being screened for cardiovascular disease risk factors compared to men is 12% less. After adjusting for age, women did worse than men in achieving guideline-based targets of the total cholesterol, of the HDL, of the LDL, of the blood glucose level, and physical activity, obesity, and sending them to cardiac rehab. The same woman and the same age of the same male coming to you after maybe for primary prevention or secondary prevention, usually they go late. again, there is also evidence that the treatment given after cardiovascular disease event in women may be less adequately, and we don't give them guideline targeted medical therapy. Just Dr. Jouairia just mentioned this in her presentation. And in the acute setting, physician may miss an acute coronary syndrome because of what is called the atypical chest pain, like Dr. Jouairia just mentioned. And during the late American guidelines during 2019, they just changed the terminology of atypical chest pain. And they came to that, they just removed completely the wording of atypical chest pain in the guidelines, and they say this is atypical form of presentation. There is nothing called atypical chest pain in a female. So we need to raise the awareness of the cardiologist and the internal medicine doctors and the GP doctors. When a female comes complaining, please just don't put the first possibility that she is psychic or she is hysterical or this is an atypical chest pain, because actually there is nothing called atypical chest pain. I just want to give you a small hint about the different presentation of chest pain in women than in men. Usually the GIT symptoms in females are more prevalent than in men. So if a woman came complaining of nausea and vomiting and abdominal pain and cold sweats, and maybe she doesn't have any chest pain, please think of it might be a heart attack. Please just put it in your back of your mind. Or some ladies will come just presenting to you with easy fatigability, shortness of breath. She cannot do her usual activity as she used before. Please don't exclude coronary artery disease. This is a little bit less in males, because more than 60% of males presenting with heart attack will come to you presenting with a typical chest pain. With chest pain in the middle of the chest, radiating to the arms or to the back. They will tell you that they have a heaviness on the chest or squeezing in the chest. So you will diagnose them immediately, and you will just, as physician, our mind is programmed. A male in his late 30s or 40s, he is a smoker, he is complaining of a chest pain. The first thing comes to my mind is going to be that he has a cardiac problem. But in a female coming to you with just shortness of breath, easy fatigability, GI symptoms, pain radiating in her neck or in the jaw, please investigate for coronary artery disease. Okay, Michael.
Thank you so much, Dr. Nerine, for this detailed information. And Dr. Jouairia, Dr. Nerine has touched base on the dyslipidemia variabilities in women and the different levels of LDL and total cholesterol in women, and especially in familial hypercholesterolemia. So can you give us more highlights into like different clinical trials evaluating the outcomes in women with dyslipidemia, and do women fare better than males in this aspect?
So, I mean, the quick answer is there isn't that many trials looking at women. So women were misrepresented in these trials. So anywhere between 25 and 30% of these trials had women in them. So, I mean, in any of these trials had like anywhere between 25 and 30% women in them. But we know that women are less likely to be on a statin. They're more likely to never be offered a statin, and they're more likely to decline it, and they're more likely to discontinue it. So this is a major problem. So as I said, there isn't specific trials looking at women, and the women are represented less, but there are multiple meta-analyses actually that looked at whether women benefit as much as men from statin therapy. And this is one of them, and it shows you that women do benefit as much as men from statin therapy, whether they have vascular disease or not. So we shouldn't deny women statin therapy just because they were underrepresented in trials. On the contrary, they should be offered statin therapy as much as men. Now, the problem here is, I'm sure like lots of clinicians have the same problem. You remember the woman that you had who had an MI and who comes in and now all her body hurts. And she doesn't really have statin intolerance, but she has muscle pain, and you think, probably she's not going to tolerate the statin and she doesn't want to continue on it. So women usually have more statin intolerance. They're more at risk of myopathy, usually have a smaller body size, lower GFR, so higher plasma concentration of statin. They're also more likely to have less adherence to medication because of polypharmacy and because of the social factors that Dr. Nerine spoke about. So women take care of the whole family. They're the primary caregiver of the house, and they have more incidence of depression and anxiety. So they're less likely to adhere to therapy. They're also less likely to reach their goals because of many factors, including having different biology and different lipid metabolism, and having also less chance to adhere not only to medication but to lifestyle changes. Also, Dr. Nerine mentioned the underestimation of cardiovascular risk factor, and that's also that's a major problem, and also the inertia with physicians, that they're less likely to prescribe statin. So if we're looking at how to treat women with statin, the guidelines do not give you different recommendation for men than women. But something that we always need to keep in mind, that secondary prevention, of course, all women need to be on statin. This is not an issue. The problem comes with primary prevention. And in primary prevention, patients who have familial hypercholesterolemia with a very high LDL or diabetics above the age of 40, or have more than their 10-year ASCVD risk more than 20%, should be on a statin. We're left with a smaller number of, or a significant number of patients who are younger, who have their risk, their ASCVD risk less than 20%. And here we have to consider all the other risk factors that Dr. Nerine spoke about. So is there premature menopause or pregnancy-associated disorders, use of tobacco, obesity, and diabetes, inflammatory disease. Consider doing calcium score to see if there is coronary calcification or not, and then discuss the issue of using statin in this patient. Of course, it becomes very difficult, especially if you're talking about someone in their 20s and in their 30s. This woman is going to get pregnant, and we're going to have to stop the medication and then restart it. So it's a joint discussion between the physician and the patient. But it's important that if we decided not to give statin, to give the advice of lifestyle modification, and to tell the patient that they have a target. So it's not just lose weight, eat healthy, and goodbye. No, it's lose weight, eat healthy, do this for 3 months, and come back and we'll recheck your lipids. Because that gives the patient more emphasis about how important this is. And if they don't reach their target, then you should consider starting them on statin. So back to you, Michael.
Okay. So thank you so much, Dr. Juwairiya. And as we see, there are like lots of disparities and things that are not enabling women to reach their optimal care for cardiovascular disease. And even when we talk about not just the female patients in cardiovascular disease, but the females in cardiology in general, or women in cardiology, we will find that like women representation in cardiology field is very low. Their contribution are like being the primary investigator or the primary author of guidelines or clinical trials is again something that needs to be improved as well. So we need a lot of work to do in the field of the females as a patients and as doctors as well. So would just like from each one of you, if you can summarize from your point of view in like 2 minutes verbally, how do you see it from your side, how we can close the gender gap between men and women in cardiovascular disease, and how we can improve this huge disparities that we have seen in the previous slides. So start with Dr. Nerine.
Again, Michael, I do believe that this has to be a combined work. Just to close this, I want to tell you that at 1990, women were completely excluded from the clinical trials of the cardiovascular trials because it was believed that this is a cardiovascular disease of men. It doesn't affect women, so they are allowed. Though the knowledge have greatly developed since the 90s till now, but still till now we are in 2022. Women in the cardiovascular trials, they are only included by 20 to 30, maximum 30% of the population of the clinical trials. So this is one item. Again, we have to raise the awareness of the physicians, first of all, that they have to take men a little bit more seriously than before. They have to know that there is nothing called atypical. There is nothing called that because she is a female, she is protected. No, this is not true anymore. So we have to take any complaint of a female just as serious as we take it for men. I do believe that we have to have something like a national program to estimate the lipid profile for all the population in general, putting in men and women, not only for one of the gender. And from this we can know, each of us we will know about our population, then the risk factor, because we know that hypercholesterolemia is one of the very strong risk factors developing primary artery disease, either premature or mature primary artery disease. So if we have the national program supported by our governments or something like this at the national level, if we have a lipid profile for all the population, maybe we can do better for our female patients. Juwairiya, what do you think?
So, I mean, I agree with a lot of the points that you mentioned. I see that we can tackle it from different aspects. So we need to increase awareness first among physicians. The risk factors that we spoke about, the traditional ones and the 6 specific ones, we need to make sure that people are aware, physicians are aware of them and understand how important they are and how can they utilize that in managing the patient. We have to increase public education as well. Women need to understand that this is a major problem. Every woman is afraid of breast cancer, but they don't understand that their primary killer is cardiovascular disease. And women, as we know, they're busy with everything. They have multiple hats to wear, and they forget, and they think that, you know, gaining weight is just part of life and there's nothing you can do about that. So it's very important to focus on these risk factors. You mentioned, we need public policy. We need campaigns to increase awareness about education and research in cardiovascular disease. The GORWIT for Women by the American Heart Association is an amazing campaign that has been running since 2004. There is the Lancet Women and Cardiovascular Disease Commission that looks at reducing global burden of cardiovascular disease in women by the year 2030. So these are important, and these add a lot to the management, to the health of women. And of course, we need to generate more evidence. We need to generate more literature to address various issues in cardiovascular disease. And this has been in the rise recently from the ESC. There has been lots of state-of-the-art review articles, and there has been more focus, as you mentioned, Dr. Nerine, about generating the evidence in cardiovascular disease in women. So I think these are the like the main ways to tackle this, to make sure that we, save all the women's hearts.
Yes, that's the right conclusion that we need to reach, just like how to save women's hearts through awareness, through education, through changes in management, through, as you said, the sex-specific data generation. These are all aspects that we need to tackle to put us on the right track to close this gender gap between men and women in cardiovascular disease. And I see lots of comments in the chat coming from women cheering for this session massively and saying that, like, this is exactly what we need to hear and this is exactly how we need to approach this topic. So Dr. Juwairiya, Dr. Nerine, we'd like to thank you so much for all your efforts, for your contribution, and for all your diligent efforts to dig for data. As you said, there are sometimes like very scarce data in this field in so many ways. So on behalf of myself and the whole Organon team, we would like to thank you so much. And of course, we have the opportunity to continue the discussion and the networking lounge for those who are interested to continue with Dr. Nerine and Dr. Juwairiya. So again, Dr. Juwairiya, Dr. Nerine, thank you so much for your efforts, for your time, and thank you again for all the whole online audience. And stay with us. We will continue with another session related to hypertension, and we have the opportunity to continue on the networking session with Dr. Nerine and Dr. Juwairiya. Thank you so much, and have a good rest of the day, everyone.
Thank you.
Thank you. Bye-bye. Bye. Okay. So thank you everyone for joining. My name is Michael Sadiq. I'm a medical advisor from Organon Egypt. And I'm happy to be your host today for the cardiovascular sessions and specifically related to hypertension. We will start by having a couple of sessions for hypertension that are really interesting. And we have a group of eminent professors and experts with us to talk about it. So we will start the hypertension track with a panel discussion titled Management of Hypertension, how can we do better? And we have 4 eminent experts from the Middle East and North Africa region. The panel will be moderated by Professor Mohammed Radwan Arafa. Professor Mohammed Radwan Arafa is a consultant and interventional cardiologist at Dalla Hospital. He is a fellow of the American College of Cardiology and American College of Physicians, and he's a professor of cardiology at, again, Dalla Hospital, as I said. So, Dr. Mohammed Arafa, without further ado, the floor is all yours.
Assalamu alaikum wa rahmatullahi wa barakatuh. I would like to thank Organon for their kind invitation for this very important meeting and very important topic. Hypertension is the main killer worldwide, and we have, as you heard, very renowned speakers, Dr. Ghazi Radiyah from Emirates, Dr. Muhammad Sadaqa from Egypt, Alexandria, and Dr. Saeed Khudr from Al Habib Medical Center, and he will try to cover some of the important issues of hypertension management. And I'm going to start by asking our first speaker, Dr. Sadaqa, to tell us about the latest data regarding prevalence of hypertension and its impact on morbidity and mortality. Dr. Sadaqa, you have about 5 minutes, please, to talk about this topic. So please go ahead.
Okay, thank you, Dr. Muhammad, for the nice introduction, and thank you for the panel and all the invitation. Actually, I'm going to talk about the prevalence of the hypertension. This prevalence, as you can see, is progressive. We know the data from 1990 to 2019. We have pulled analysis from more than 1,200 population representative studies with more than 100 million participants. The number of people aged 30 to 79 years with hypertension is doubled from 1990 to 2019. As you can see, from 331 million women and 317 million men in 1990, the total number is 648. The total 626 million women to 652 million men in 2015. So these numbers actually is doubled from 648 million to 1.2 billion population having this lethal disease, as we can see this disease. So control of hypertension is a little bit not doing good till this moment, despite of the good quality of antihypertensive medication. Also treated patient not controlled and diagnosed but untreated, representing also more than 20% of the population, and undiagnosed population representing more than 50% of this 1.2 million population. What about the global impact of elevated blood pressure? The global impact of elevated blood pressure, it representing more than 10 million deaths worldwide, over 200 million disability adjusted life year, representing that 5.9 million is affection, 2 million hemorrhagic stroke, and 1 and only 13.2% are controlled. So we have only 35% of the population are controlled. Hypertension and increased cardiovascular disease. There are an association between high systolic blood pressure and diastolic blood pressure and increase in cardiovascular risk. The risk of cardiovascular disease is increased in log linear fashion from systolic blood pressure less than 115 up to more than 118, and from diastolic blood pressure less than 75 up to 105. 20 millimeter rise in systolic blood pressure and 10 millimeter rise in diastolic blood pressure were each associated with doubling of the risk of the death from stroke, heart disease, and other vascular disease. And the high blood pressure related increase in absolute risk in large population, also more than 65 years, given the higher absolute risk of cardiovascular at old age. And you can see here on the left side the rate of major cardiovascular event per 5 millimeter mercury reduction in blood pressure. If the patient had already cardiovascular disease, you have almost 11% relative risk reduction of the major cardiovascular event. And for those who have never had a cardiovascular disease, it's only 9% relative risk reduction if you are going to treat those population and reduce the systolic or diastolic blood pressure by 5 millimeter mercury. And actually, the prevalence of controlled blood pressure decreased over time. If you can see here from 1999 up to 2019, the rate of control is increasing, then become decreasing later on. So this is our main problem here in this disease. Thank you, Dr.
Thank you very much indeed, Professor Mohammed Sadaq, about this very important introduction. Now we'll go on to Professor Ghazi, and we will ask him kindly to tell us about the epidemiology data regarding prevalence of hypertension in our region here in the Middle East area and North Africa, and the control rate. Dr. Ghazi, please share your slide and go ahead.
Assalamu alaikum. It's my pleasure to be with you today, and my job is just to continue where Dr. Sadaq stopped concerning the hypertension, which is the most common chronic disorder worldwide. Let me start with this. I hope you are seeing my slides.
We need to put you on full, it's not really in full mode now.
Okay. All right. Is it okay?
Not yet.
On a slideshow.
Slideshow is okay. This is slideshow.
Full images now. Yeah, now put it now. That's fine.
Okay. All right. So do you see it?
Yes, sir. Now.
Yeah. Okay. So I will continue where Dr. Sadaq stopped concerning this chronic disorder, which is the most common disorder worldwide. We know that hypertension is a serious problem, and it is worldwide. It is very obvious that it is the most common, but we are also in our region, it's a very common disorder. This is a slide taken a long time ago and published earlier. It showed that the prevalence of hypertension in the Gulf countries was ranging from 50 to 21%, and this is reflecting the time when the blood pressure was considered as 140, 90, and below should be. The second slide is also taken from the Gulf countries, where show the control rate was not unique between these countries, although they are neighbors and brothers. But in Kuwait, you will find 40%, but in Egypt, down to 8%. What I want to say that we are suffering in this part of the world, not from the prevalence of hypertension, that this is very common, but our statistics and the studies are very, very limited. This study was published 2-3 years ago, and we participated in from our side within this study. It reflected the prevalence of hypertension and control in 4 countries: United Arab Emirates, Saudi, occupied Palestinian territory, and Iran. The number was huge, more than 10,000, and the statistics showed that the prevalence was 33% on average between the 4 countries. But if you want to go in details, you can look to the side, on the right side, where there is differences in the rate in each country. The awareness was only 49%. The treatment for the patients, nearly less than 50%. But those who were treated, hardly they reached to the control, which was 19%. And this is not unusual in this part of the world when it comes to the control. There is a recent study. I took this. There have been a lot of studies in Saudi, particularly in the last 10 years, about the epidemiology and the prevalence. I took it from Tabuk because it reflects the prevalence of hypertension in patients from the military setting up. They screened nearly less than 1,000, and it showed clearly that the incidence of pre-hypertension, because they used the criteria of ACC and HA17, where they look for the BP, which should be 130 and 80 and below. The elevated blood pressure was reaching 60, the stage 1 hypertension 29, and the stage 2 is 7%. There is another study from Jordan, was taken, published 2-3 years ago, where they found in nearly 5,000 people screened with for that, and they found that the prevalence reaching 33% in men and 30% in women. Nearly 1/3 of the adult population in Jordan, they are hypertensive. A lot of them are aware, but it is hardly reaching 60%. And when it comes to the control, it is similar to other countries, is only 30 to 35%. And the last study, which is considered a major study, this is a meta-analysis about the prevalence in the MENA countries, and MENA involved a lot of Arab countries and our neighbors from Turkey to Iran to Ethiopia, etc. But Turkey and Ethiopia were not included in this study. And they looked to the details of this study, where it was the prevalence is similar to the previous studies, reaching to the 30%. But when it comes to the awareness, nearly 51%, the prevalence of patients being treated 47, and if they were treated, reaching to the target on 43%. So it is similar to the previous studies from Jordan and Saudi. If we compare to what is available from the international era, this one taken from USA, the importance of this slide to show that the prevalence of hypertension is strongly affected by the target and the threshold which we use. When we were using 140, 90 and as a target or a threshold, the prevalence was nearly 32, 33%. But the moment when they start using the criteria of 130, 80, it jumped to 46%. And this is not far away from Europe. When we were using 140, 90, the prevalence was around 40, 42. But the moment we start applying the criteria as 130, it is reaching 60 and above. The message from what briefly these slides which I presented, that the studies in hypertension are disparately different from one place to another. The prevalence is increasing, and this is very important for us, for the healthcare providers, to look more details about the hypertension in the term of diagnosis, treated properly, and if they are treated, we should observe to see whether they reach to the target so as to reduce the cardiovascular events. And I will stop here, allowing for the third speaker.
Thank you very much indeed, Professor Ghazi. Very, very impressive presentation about what current situation now we have. Now we'll move on to our guests from Riyadh, Saeed. And we would like to ask you, what are the reasons really behind the suboptimal hypertension control among different patient population? Professor Saeed.
Thank you very much, Dr. Muhammad. I thank for Dr. Sadaqa and Dr. Ghazi for their nice introduction. Certainly, as a diabetologist, this data is really depressing for us as a primary care or as a physician, because we have the disease very common and unfortunately underdiagnosed, undercontrolled. And as the both speakers said, in spite we have too many antihypertensive medication on the menu, we are not achieving the target. And we are the same as in Europe, by the way. So in our area, we are not as bad as we believe. We are the same as UK and other countries in the world. The question why we are not achieving the target, as diabetologists, with all my patients having a lot of polypharmacy, a lot of medication, some of them they are on 8 or 9 medications, sometimes more. We have a problem with non-compliance and adherence. That's why probably the patient not achieving the target. The other things, probably as Dr. Ghazi said, probably we are not yet diagnosed a lot of patients, but non-compliance is a normal behavior of human being. Also, a lot of the social media, when they speak about the antihypertensive medication and the side effect, and Dr. Arafa, you remember at one stage there was on the journal here in Saudi Arabia that antihypertensive medication causes erectile dysfunction. A lot of my patients, they stop their antihypertensive medication immediately. So this is one reason, non-compliance and adherence. The other things which sometimes as physicians we forget to review the medication and we don't communicate with our patient. It could be suboptimal treatment. Sometimes we don't reach the maximum dose of antihypertensive medication. So either the dose is too low or we don't know the right combination, for example, diuretic and ACE or ARBs and diuretic. Inappropriate combination, dietary, sometimes we have to ask the patient to decrease the salt, which is very, very important. Normal behavior sometimes that the patient with junk food, too much salt, will affect the control. Physical activity, to encourage physical activity. The other things we have to review the medication and other comorbidities. Obesity, one of the factors, that's why whatever we are giving, not achieving the target. Smoking, excess alcohol or excessive alcohol consumption. A lot of my patients, they have whatever pain, low back pain or knees pain because they are elderly, they have osteoarthritis, rheumatoid arthritis. The pain itself increases the blood pressure. The non-steroidal anti-inflammatory drug will increase the blood pressure. A lot of patients on steroid, unfortunately, a lot of young population now on ecstasy and amphetamine. All these things, even the juice that sometimes we use it liquorized, can increase the blood pressure. Using anticongestant by our colleague, the ENT, sometimes might increase the blood pressure. We have to understand also the secondary hypertension. It could be secondary causes as endocrinologists, pheochromocytoma, cons. It's really not uncommon, but again, we find a lot of patients, renal artery stenosis in elderly people and even in young. It could be thyroid problem, endocrine problem. So I think the other major problem which we start to see is those patients with sleep apnea. Obstructive sleep apnea is very, very common, and it could be one of the causes why we are not achieving the target. So basically, we need to communicate better with our patients to have better compliance, better adherence, and we have to warn those on the social, using the social media, not to blame too many of these medication as a cause of erectile dysfunction or comorbidity, etc. And probably we have to review the medication when we start or when we look why this patient not achieving the target, using the proper combination and probably a teamwork, probably using a hypertensive nurse to communicate with the patient, probably we will achieve better control. And I'll stop here. Thank you.
Thank you very much, really, Professor Saeed. Very informative. Now we'll move on to second question to Professor Ghazi about the most recent recommendation for management of hypertension. We have the European Society of Cardiology, European Society of Hypertension, we have the American Diabetic Association guidelines, and we have the... So please, Professor Ghazi, address this issue about what we have recent recommendation.
Okay, thank you very much, Professor, for this introduction. I will continue. Is it clear for you? Or you
yes, make it on full screen, please. Full screen.
It is okay now. Okay. So this slide is showing all the guidelines which had been available for those who are practicing like me for the last 30 to 40 years. This was a clear cut that for ages we were dependent only in one line of the guidelines. We were happy to move from JNC 1 to JNC 7. I personally was happy because this was the only one and there was no confusion with the other guidelines from the other countries, etc. The 21st century started and there is a lot of guidelines start to appear on service. By the way, all these guidelines depend on the same evidence, but the interpretation of this evidence make the doctors around the world to have their own guidelines with some changes. What we are concerned in the Middle East is about the American College of Cardiology or AHA together or European Society of Cardiology. And recently the Europeans start to attract the attention more and more, at least for our doctors who are practicing in this part of the world. And also the ADA has a place particularly between the diabetes. After the study which called the SPRINT, which is not drug-induced or supported by drugs, it is supported by the government of USA, it showed clearly that the intensive treatment with medications far much better than the standard treatment when we were happy to push blood pressure down to 140 and stop there, because we were afraid that medication will cause a lot of problems, particularly after the previous studies that occurred, etc. And it showed clearly that if you lower the BP, you are going to get benefit more in the cardiovascular reduction. Based on that, the guidelines, American College of Cardiology, AHA, they started a new classification showing that the normal blood pressure is 120 and the elevated one 129, stage 1 after 130. The European Society of Cardiology soon or after that, in 1 year or less than that, they introduced their own classification, and this created a lot of puzzles for us, particularly for the junior doctors, because of the classification which is not matching. What is considered normal for European is already elevated for the American guidelines. What is considered high normal, whereas the treatment with medication is rarely indicated, is already stage 1 hypertension for ACC AHA guideline. That is why they made it clear that every patient on treatment, they would like to see that the target reaching 130, 80 and below that, no matter what is the age or the comorbidities. So you need one figure. It is easy for the practicing doctor, but there are a lot of resistance in relation to this, particularly in elderly people, because 130, 80 probably will be associated with some kind of postural hypertension, etc. When the European guidelines appear, if you look in details, practically they agreed with this level indirectly. But for those patients who are below the age of 65, 130, 80, except the patients with chronic kidney disease, where they would like to look for the blood pressure similar to the others. But the moment you are above 65, they are happy to lower the BP to this level, 130, 139. If the patient can tolerate to go down, but never cross the 120, like had been mentioned earlier, and they're still using it in Europe. There is one clear message from the European Society of Cardiology, which had been emphasized from ACC, that for those patients who are not labeled to be at high risk or very high risk, please check the global risk factor for this patient. Because if there is a risk high, push for medication earlier than when there is no high risk. And all of you are aware of the risk calculation and the risk which is used. When it comes to the threshold, European, they decided to go by the age, treat if the BP more than 140, 90, if the age is less than 65. If the age is more than 65, the same level. If it is more than 80, try not to push medication before the level reaching 160/90. However, if there is a very high risk, push down below 135/80. And the target you treat to reach the BP to less than 140 systolic in all the ages almost, but don't go below 120. However, this is not mentioned in American guidelines, which level to go when you are treated. The management is clear. Everybody is aware of the guidelines. The step-up approach for hypertension, we are aware of this from the time of GNC3 and before. Start with lifestyle modification, no matter which grade of the hypertension, and then move to the medication according to the risk and according to the priority in terms of cardiovascular reduction. However, this is a new, which is emphasized in guidelines, that we would like to reach to the control within 3 months. In other words, treat fast, and if the patient is not getting the proper blood pressure control, push more medication. Get the control after a short period rather than the previously when we were slow in building up the medication. The treatment is very clear. Every patient, in addition to the lifestyle modification, should be on dual anti-hypertensive medication or combination therapy. Exception from that, exception and not as a rule which we were using it before in the previous guideline. Only in those who got young people, systolic blood pressure less than 150 and no target organ damage, or very, very elderly above the 80 years, because everybody is afraid from posture. The rest should be in at least dual therapy. And it is part of the guidelines. So most of our patients should look to this line. In case that the patient needs combination, the combination is clear. RAS inhibitor plus diuretic or calcium channel blocker. This is a clear chart showing when you are having hypertension uncomplicated, it is a clear line. But whenever there is a patient with complicated hypertension, coronary artery disease, chronic kidney disease, atrial fibrillation, heart failure, here the first line medication will include beta blockers, which had been pushed earlier by the guidelines down. Because if the patient has ischemic heart disease, the priority to use beta blockers in addition to RAS inhibitors. Same with AF or heart failure. In patients with diabetes, look always for the risk factors global. If the patient has got just blood pressure and diabetes, decide for the target individually. If the patient has evidence of high risk, where the risk score above 10%, or atherosclerotic cardiovascular disease, try to push to 130/80 and below, which is good for the diabetic patient. In case that the risk score is higher, less than 10%, probably most of the diabetologists as well as the cardiologists will be happy to consider that the target is 140/90 and below. And I think I will stop here for the sake of the time, and I will allow...
Thank you very much, Dr. Ghazi, Professor Ghazi.
Thank you very much. Okay.
Very clear and obvious. Now we'll move on to Professor Muhammad Sadaqa, and I would like to ask you, if you don't mind, about the benefit of using R plus hydrochlorothiazide combination in terms of reducing blood pressure and enabling patient to be really reaching the target. So using ARBs plus hydrochlorothiazide combination to reach the target. Please, Professor Sadaqa.
Okay, Dr. Muhammad, can I share my slide, please?
Please, go ahead. It's all yours.
So actually, as Dr. Ghazi said, we have the core drug treatment strategy for uncomplicated hypertension stated by the guidelines that you can start by one pill combination. This is as recommended by the guidelines. So you need to use one pill initial combination, and the best combination you can choose is ACE inhibitor or ARBs combined with calcium channel blockers or diuretics. You can mix and match between ACE and calcium channel blocker, ACE and diuretic, ARB and diuretics, and so on. And as Dr. Ghali said, you can consider monotherapy in low risk grade 1 hypertension in very old population, also more than 80 years old. So this is the only two situations you can start by monotherapy. But most of the patients should start by combination therapy. If the patient is not controlled on the dual combination therapy, you can give him a chance of 4 weeks at least. Then you can up titrate into triple combination therapy. This recommended combination is ACE or ARB plus CCPs plus diuretics. And thanks to the next technology that we have now, single pill combination, having the 3 drugs in one pill to increasing the patient compliance and increasing the adherence. So, what about the benefit of dual therapy over monotherapy, and what are the benefits of single pill combination rather than free combination? As you can see here from this data published by Egan in Hypertension Journal in 2012, that if you are going to use monotherapy, the blood pressure control is equal between worsening of combination or better combination. But when you use the free combination, blood pressure control is better with combination rather than monotherapy. And if you are going to jump in a single pill combination, this is a furthermore tight control of blood pressure. So we are all that we are convinced that the single pill combination, whether dual therapy or triple therapy, is much more better than free combination or even monotherapy. So what about the risk of cardiovascular event in a patient on initial separate combination or free combination or monotherapy? When you look at this data, comparing monotherapy or combination therapy for any vascular cardiovascular event, of course, combination therapy will beat monotherapy. Also in heart failure, combination therapy is the winner rather than monotherapy. When you look at the cerebrovascular disease, also combination therapy is much more better than monotherapy. In the case of ischemic heart disease, of course, combination therapy is the winner. And finally, in terms of death, combination therapy is much more far better than monotherapy in outcomes. What about the advantage of the ARB plus diuretics for combination therapy? Actually, when you are going to use two drugs like ARB and diuretics, you are getting to hit 2 mechanisms of action in hypertension. You all know that hypertension is based on 3 mechanisms: the RAS activation, the salt-to-water retention, and the sympathetic overactivation. We all know that if you are going to use RAS blockade, this RAS blockade have a vasodilatory effect and sodium volume reduction, leading to lower in blood pressure. And also the thiazide diuretic leading to natriuresis and volume depletion, and also it lowers the blood pressure and it antagonizes the RAS blockade reactivation by renin release. What about the incidence of ankle edema if you are going to combine ARBs and calcium channel blocker? Of course, if you are going to use CCP monotherapy alone, we all reported that many cases have an ankle edema with higher incidence, especially in female. And this capillary overload is fluid occurred because of the CCPs is dilating the arteries rather than the veins. So after a few weeks of therapy, patient getting this peripheral edema. And this is one of the caveats that many of the patients are refusing to use CCPs alone, and they are afraid from this side effect. If you are going to combine CCPs with ARB, the ARBs dilate the arteries and also the veins simultaneously, so the venous return become equal, so they reduce the peripheral edema. So I think the best combination therapy right now, as stated by the guidelines, that if you are going to use a single pill combination is the winner, especially if you are going to use ARB and diuretics or ARB or CCPs and other than ACE. Thank you.
Thank you very much indeed, really very impressive. Now we move on to the last question for Dr. Saeed about we need really to some elaboration, just more information about protection of organs. We need to know about the end organ protection offered by different ARBs, especially in the diabetic and hypertensive with left ventricular hypertrophy. Dr. Saeed.
Thank you very much, Dr. Muhammad. Thanks for the speakers as well. I mean, certainly we are as diabetologists, endocrinologists, when we treat, we try to prevent cardiovascular complications. This is our aim. Even when we start to use now anti-hyperglycemia, we start to take the drugs with evidence base that they are cardioprotective and nephroprotective. Certainly when we choose the antihypertensive medication in diabetes and in other patients, but just in diabetes, we try to prevent those at high risk or very high risk, especially if they have target organ damage. And I can assure you, most of the patients in my clinic, they are either high or very high risk group. So the target organ damage, as all we know, it's not only just cardiovascular, it could be coronary artery disease if the patient have left ventricular hypertrophy or heart failure, or if he has cerebrovascular disease, stroke, if he has multi-infarct dementia. The other thing, sometimes we have to check the eye just in case if the patient has retinopathy, because the combination of hypertension and diabetes that lead to retinopathy is very difficult to treat. I usually examine the patient to check if he has peripheral arterial disease, also check for microalbuminuria. As we know, in patients with diabetes, microalbuminuria, it means a premature cardiovascular disease, and usually we check just in case if there is chronic kidney disease. So all these are target organ damage. So I've been told probably to speak about which medication. I will take just ARBs, for example, losartan, and one of the studies, the losartan and organ protection big data trials. This is the life study, which is just for the sake of time, not going to go in details, but this life study, they took life in investigators set out to evaluate whether losartan was superior to atenolol, which is the old beta blocker, in reducing combined cardiovascular mortality and morbidity in hypertensive patients with left ventricular hypertrophy. So there is target organ damage, and what they've been looking for, it was a huge study, and from 945 centers, the comparative trial between losartan and an established antihypertensive here, the atenolol. So looking for the primary composite endpoint to see the stroke, cardiovascular death, and MI. There were around 1,000 hypertensive patients with left ventricular hypertrophy in the trial, and the trial the duration was 4.8 year mean follow-up, and around 945, I said, centers in 7 countries. And this is the inclusion criteria typical to our patients in brackets. They age between 55 to 80, and we know that we have younger than that in the Middle East. Previously treated or untreated hypertension, diastolic blood pressure being between 95 to 115, systolic 160 to 200. Probably this is the old study, which is really very high blood pressure, and they have left ventricular hypertrophy. The conclusion from the study, just very quick, that the life study in hypertensive patients with ECG left ventricular hypertrophy demonstrated that ARBs, and here losartan, was superior to beta blocker by 13% risk reduction in the primary composite endpoint, stroke, cardiovascular death, and MI, 25% risk reduction in stroke, 33% reduction in a new onset of atrial fibrillation, which is very, very important to prevent atrial fibrillation in patients with hypertension, and 40% risk reduction of stroke, especially in patients with isolated hypertension. So for patients with diabetes, especially those high or very high risk or even low risk, I will choose as the guidelines, as Dr. Ghazi mentioned, for any patient with hypertension, the guidelines mention dual therapy or combination therapy between ARBs, ACE, and diuretic. The same for patients with diabetes. And I can assure the physicians who are in the audience that using diuretic will not harm the patient with diabetes, and it never increase the incidence of diabetes. So you can use it. The other study here, which we look for, reduction of endpoint in here type 2 diabetes, non-insulin diabetes with ARBs, losartan here, which is the renal study, because we are looking for cardioprotective, which is again a good study and large number of patients, around 1,500, 1,513 patients from 250 centers in 28 countries, to see if using ARBs here, losartan, can decrease the prevalence or decrease this complication. So renal study results show that losartan provided renal protection. Okay, so cardioprotective, 28% reduction in end-stage renal disease, 32% risk reduction in hospitalization for heart failure, 35% reduction in proteinuria. And now because we have the SGLT2 inhibitor, so this is another things that we can add to patients with type 2 diabetes. What about comparing the losartan heart failure survival, the ELITE-2, to compare between using ARBs here, losartan or captopril? There was no differences, but the differences was that in losartan ARB, less side effect and probably better adherence. So in patient with symptomatic heart failure due to systolic left ventricular diastole, no statistically significant difference were observed between losartan and ACE or captopril. With respect to all-cause mortality, they are the same. Composite of sudden cardiac death or resuscitated cardiac arrest, they are the same. Composite of all-cause mortality. So basically, more or less, they are the same, but there was big difference in the adherence. Seems to be the patients on the arm of ARB, they have better compliance and better adherence and less side effect than ACE inhibitor, especially the dry cough, which is a good number of patients or percentage will have a dry cough from the ACE inhibitor. So the general strategies for me to improve the adherence, what we suggest, we have to have a team-based healthcare incorporate with the pharmacy. We should have probably hypertensive nurse. Behavior intervention, very, very important. Sometimes we might call the patient to come back to the clinic. Education is important. Support by a nurse, by a dietitian, by educator is important. We have to put a target. Dr. Ghazi and Dr. Sadaka mentioned what sort of target, individualized. Patients with diabetes, the target to be around 130/80, especially those with microalbuminuria. So it's very, very important that to put the patient in the center of our care. And certainly it's very, very important to look at better adherence, to use combination, follow the guidelines, ARBs or ACE with diuretic. We have to teach our patient, educate, simplify medication, simplify the regimen that we are titrating, and we have to use probably single fixed dose combination better than the free combination. And at one stage, please review the medication, especially if the patient not achieving the target. We have to ask our question, if not compliance, encourage or adherence. Think of secondary hypertension, especially in young people. Think of renal artery stenosis in elderly and other non-steroidal anti-inflammatory, etc. From that could be the cause why we are not achieving the target. And don't forget the sleep apnea. Thank you very much.
Thank you, Dr. Saeed. Thank you, everybody. Now, before we go on to the Q&A section, I'm going to ask every speaker from the group here to give us how his point about the optimal control of blood pressure in 2 or 3 sentences only. So summarizing everyone his thought about optimal control of blood pressure. Mr. Professor Ghazi, in 3 words, how you optimize treatment for blood pressure, Professor Ghazi?
Yeah, you mean when it comes to the optimal, there is nothing what called optimal. There is what called accepted rather than optimal, because there is confusion between the 2 guidelines between optimal or normal. What we assume that if we put a target of blood pressure, we want to reach to that target. That is what called control or optimal management. What I am doing in my practice, and this is matching with what internationally accepted, the aim when we see the target, treat the patient to lower the blood pressure systolic less than 140. That is number 1 in every patient. Number 2, in certain groups where the patients, they can't tolerate to go down, push for more blood pressure to go down to 130 or even below 130. But no matter which type of patients do you have, don't cross the 120 to reach 120 or 115 or etc. with medications. Then you will be on the safe side. Certain group require BP to remain there at a lower level. Others, probably if you push to 140 and below, you will succeed in reducing the cardiovascular events. So these are the 2 steps in, and avoid the side effect of medications, because the cost will be high. Whenever the patient developed symptoms, he is likely to stop his medications.
Great. Dr. Professor Muhammad Sadaqa, please, your thought about recommendation for the target control or optimal control or the best control for blood pressure. You are muted, Professor. You are muted. Dr. Muhammad, please.
Sorry, Dr. Arab. Actually, to answer this question, regardless of the drug employed in the treatment, you are going to choose fixed dose combination from the beginning. This is my first advice. Don't waste time by monotherapy. And by presence of the majority of this combination, I usually started by ACE or ARB in combination with calcium channel blocker and thiazide diuretics. I give the patient some advices regarding the hypertension, some information about what is hypertension and what to control and how to control and what are the targets you have to reach. And I think that if you spend some time with your patient in a couple of minutes, I think this will be reflected on the achievement. Thank you.
Professor Saeed, please.
Thank you very much. And I agree with my colleagues, but certainly first I will add the following. Please screen for hypertension. So we should check the blood pressure if he's going to surgery, if he's going to whatever clinic. It's very, very important. So screen, diagnose, treat, use combination therapy. Please improve the adherence to those patients by education. The other things, think of the causes, why he is not achieving the target, review his medication, very, very important. Try to also concentrate on other comorbidity that it could be the cause. And please don't forget that 5 to 10% of patients with resistant hypertension consider to refer to endocrinologist to rule out secondary hypertension. Thank you.
Well done. Now let's have a couple of questions from the chat box here. We have the concern about patients who come with really high, very high blood pressure. We call it hypertension urgency. And how fast should we lower the blood pressure? So we start with our senior colleague, Professor Ghazi. You have been living through this for 40 years now, Professor Ghazi. So what should we use nowadays and how fast should we go?
Yeah, you mean when it comes to the treatment of hypertension, we have to be clear what do we mean by urgent treatment. Is this emergency or urgency? That is a very big difference between both of them because the type of medications which is needed is different. When it comes to the emergency, you have to use IV medications. When it is urgency, probably with oral anticoagulation, you can succeed and you will do well. Number two, every doctor has to know what do we mean by emergency in which condition. And here it comes the presence with high blood pressure together with papilla edema, stroke, MI, pulmonary edema, acute renal shutdown, or ischemia of the lower limbs. Then use the medications IV and the ICU people, they know which drugs to use. When it comes to the urgency, probably with medications, but here emphasized on combination therapy. There are some differences in the strength of the antihypertensive medications, and there are some drugs which can be used safely in this or that drug patient. Not to forget the preeclampsia and the patients with pregnancy. So the medications are there and you can use them with observation of the blood pressure and the response.
Thank you very much indeed. We have to stop here now, and thank you all of you really for your participation today and for Organon to invite you with us tonight. And really, we have learned a lot. We have to control blood pressure. It's a major killer. So do your best, do the best combination, and thank you again. We'll see you again in another meeting. All the best luck. Thank you.
Thank you so much.
We will meet. We will have to go ahead. Yes.
Thank you so much, everyone. Thank you, Dr. Muhammad Afa, Dr. Ghazi Radayda, Dr. Saeed Khidr, and Dr. Muhammad Sadaqa for your valuable contributions. And now for all the audience watching us online, we will move to the last session of our program today. And for all the speakers and moderators here, if you want to move to the networking area where you can interact with other audience and other speakers as well, you're most welcome. So thank you so much, everyone, and we will switch to the next session right away.
So we will go for the next link, you mean?
Yes, of course, sir.
That is okay. All right.
Thank you. Okay.
So we will leave this one. We will leave this one.
Thank
Yes.
you very
Okay.
much. Thank you.
Bye-bye. Bye. Okay. Hello, everyone, and thank you for being again with us. We are at the last session of a very condensed and comprehensive day for the cardiovascular franchise and Oscar meeting with us today. So we've been through different sessions around dyslipidemia and hypertension, and now we're having the final session of our day, which is called Day-to-Day Challenges with Hypertensive Patients. So today we will examine two cases for hypertensive patients with different scenarios, and we will have interactive polls with you that are available on your screens. So we encourage you to vote for the options that you find relevant for the cases. So we have two eminent speakers with us today who will be sharing their thoughts around management of hypertension in different patient populations. Of course, we'll have with us, first of all, Dr. Ahmed Abdurrahman Al-Sadiq. Dr. Abdul Ahmed, he's a consultant endocrinologist in Sulaiman Al-Habib Medical Group in Saudi Arabia. And Dr. Amin Al-Jayusi. Dr. Amin, he's a senior consultant for endocrine and diabetes at Hamad Medical Cooperation Center in Qatar. He's an associate professor at Weill Cornell Medical College in Qatar. So without any further ado, I will leave the floor to Dr. Ahmed Al-Sadiq to start talking to us about the first hypertensive case that we will encounter today.
Bismillah ar-Rahman ar-Rahim. Thank you for organizing these sessions. And today I'm going to present this case which involves this 52 years old male patient who had a medical past history of type 2 diabetes for 8 years. He was also diagnosed with hypertension for 4 years and hyperlipidemia. He works as an accountant and he's a smoker. He has been smoking for more than 12 years. He's married with 3 children. When I saw him, his parameters showed that his weight was 89 kilograms with a height of 177 centimeters. That's giving him a BMI of 28.5, and he's clearly overweight. His heart rate was 74 beats per minute, and his blood pressure was 159/89. Clinical examination of his chest and cardiovascular system revealed no abnormalities. His lab test showed that his HbA1c is slightly suboptimally controlled with HbA1c at 7.1%. His creatinine was 98 micromole per liter. His ACR was normal. His LDL cholesterol was 1.8 millimole per liter. In the ECG, there were some signs of LVH by the voltage criteria. So we have this 52 years old male patient with hypertension, diabetes, and hyperlipidemia, and clearly here his blood pressure is high and he's overweight. His medications on presentation were metformin 1000 milligrams twice daily, and he was also on dapagliflozin 10 milligrams once daily for his diabetes. For hypertension, he was on amlodipine 5 milligrams once daily, and he was taking rosuvastatin 20 milligrams once daily for his hypercholesterolemia. And he was compliant with all these medications. So at this stage, I'm just going to put this question here, and just to see your thoughts about the target, possible target systolic blood pressure for this patient. Is it less than 140 or less than 130 or less than 120, or maybe we can accept less than 145? If you can just start giving your thoughts now and vote, and we'll see how your thoughts are, and we'll discuss the results. You can start now. Okay, do we have the results?
Second, Dr. Biscuits is coming, so give me a second.
Okay.
Yeah, so 57% saying less than 130, then followed by 40% for less than 140, and almost 4% for less than 120, and 0 for less than 145.
Good. I think this is the. Thank you. Thanks for sharing the results with us. I think this is a reasonable answer, with maybe the majority, more than 50%, agreeing that we should aim for a systolic blood pressure in this case of less than 130. And I think this is in line with the commonly followed guidelines. 140 maybe is a little bit high, and the others, 120 is a little bit too well, or possibly too tight. 1 to 45 is neither here nor there. So I think 130 is a reasonable systolic blood pressure target for this patient. So another question here, if you can again just see your thoughts about it. As you remember, this patient was on 5 milligrams of amlodipine. His blood pressure was high still, 159/89, and he was on amlodipine 5 milligrams once daily, and he was compliant, but he was still having high blood pressure. So if you want to achieve this target of systolic of less than 30, is it reasonable to A, increase his amlodipine to 10 milligrams, or change to an AC inhibitor, or maybe consider changing to an ARB with a thiazide diuretic in a combination tablet? Or maybe we just keep going as the situation is. So if you start voting, and we'll see your thoughts in less than a minute. Right, do you have any results? No?
Not yet, doctor. Just let me check. Yeah. So yeah, 50% for change to ARB plus thiazide, 23% to increase amlodipine to 10 milligrams OD, and 17% to change to an ACE inhibitor, and 10% continue with the same medication.
Okay, good. Almost 50% are saying it's change to ARB plus thiazide diuretic. And that's an obvious answer because all the session is about this. not exactly, but I think this is a reasonable answer. We'll go through these answers one by one. Increasing amlodipine to 10 milligrams once daily. Yes, we can increase it, but it will give some modest decrease in the blood pressure. We will probably not reach the target. And at the same time, as you remember, this patient has type 2 diabetes, hypercholesterolemia, he's hypertensive, and he has LVH. So we should be aiming for a medication to target all these comorbidities. Changing to an ACE inhibitor is a reasonable choice, but might also not be quite enough to get us into the goals. Change to ARB thiazide, yes, that's possibly a reasonable answer. Continuing the same medication will not achieve anything, so we'll keep him on the same level of the blood pressure. If you go back to the 2018 European Society of Cardiologists, European Society of Hypertension guidelines, just to remind you that they're recommending that in hypertensive patients who have heart failure with reduced or preserved ejection fraction, the blood pressure lowering treatment should be considered if the blood pressure is more than 140/90. In patients with heart failure with reduced ejection fraction, they recommended a blood pressure lowering treatment comprising of an ACE inhibitor or an ARB and a beta blocker and a diuretic or any renin-angiotensin agent. The dihydropyridine calcium channel blockers may be added if blood pressure control is not achieved. So this patient already started on calcium channel blockers, but we should really try to modify his medications. So they said that no specific drug has proven its superiority and all the major agents can be used. In all patients with LVH, it's recommended to treat with a RAS blocker in combination with calcium channel blocker or diuretic. RAS including the ACE or the ARBs. And the systolic should be lowered to a range of between 120 to 130. So between 120 to 130, not less than 120 and not more than 130. So this is a reasonable guideline, I think. And in our case here, this clearly applies. The patients with hypertension who has a systolic of more than 160 and a diastolic of 100, they should be initially treated with a combined antihypertensive therapy. This approach has some advantages. About 2/3 of the patients, they can achieve their target blood pressure, and the time taken to reach blood pressure control is reduced. We don't wait until we sequentially increase the medication, so we gain time here. The components of the two combinations, obviously they will have a synergistic effect in terms of the blood pressure lowering and the duration of action. Each will work in different pathway. There's also less likelihood of adverse effects because of the lower doses used in this combination. Adherence to the treatment is also increased because it's only one pill combining two medications, especially if it's a fixed dose combination. And obviously the hypertension carries a lot of risks and morbidities for the patient, including or targeting many different systems. But our focus here in our patient is about the left ventricular hypertrophy and the heart. Target organ damage, as I mentioned, it can involve different systems, but in the heart, it can cause left ventricular hypertrophy, coronary artery disease, and heart failure. It can also cause stroke or transient ischemic attacks in the brain. It can cause kidney failure, peripheral arterial disease, or retinopathy. From the Framingham Heart Study, as you remember, hypertension increased the risk of cardiovascular morbidity and mortality, here by even double the risk for both men and women. And again, from the Framingham, the risk of cardiovascular event associated with patients who are elderly, hypertensive, and they have ECG evidence of LVH, again, their risk of cardiovascular events is increased significantly. The cardiorenal manifestations for type 2 diabetes patients are the first manifestations of complications in these patients, especially chronic kidney disease and heart failure. Heart failure may be accounting for about 1/4 of these complications or comorbidities with type 2 diabetic patients. This is a large study here from different European countries, also from Japan, as you can see. Just quickly run through LVH. Obviously, it's a condition in which there is an increase in the left ventricular mass, either due to the increase in the wall thickness or due to the left ventricular cavity enlargement, or both. And most commonly, the left ventricular wall thickening occurs in response to the pressure overload, and chamber dilatation occurring in response to the volume overload. The LVH is present in about 15 to 20% of the general population from different studies. It's more often is prevalent in the elderly, in the obese, and in patients with hypertension. A review of the echo data from more than 37,000 individuals in the US revealed a prevalence of about 19% to 48% of LVH in untreated hypertensive patients and 58 to 77% in high-risk hypertensive patients. The presence of obesity causes double the risk for developing LVH. And LVH is a cardinal manifestation of preclinical cardiovascular disease. 2/3 of the patients with LVH, they are hypertensive. So there is a very tight correlation here between both problems. BP control is essential for preventing further deterioration and complications from LVH. In hypertensive patients, LVH strongly predicts the risk for myocardial infarction, stroke, and cardiovascular death. ECG is the one or the tool which is most commonly used to diagnose LVH, and it's readily available everywhere. Its specificity is relatively high, but sensitivity makes the clinical utility somewhat limited. The LVH diagnosed by ECG is strongly impacted by both the age and ethnicity. While the electrocardiography is not sensitive and cannot be used to definitely exclude the diagnosis of LVH, it still plays a diagnostic and management role in management. Echo is a test of choice in establishing diagnosis of LVH, and we can sometimes use the MRI, which can be really superior to these other two tests, but that might not be available everywhere. LVH is considered an independent major risk factor for cardiovascular disease, and the reversal of LVH appears to be a desirable therapeutic goal in hypertensive patients in order to reduce their increased cardiac risk. The role of the RAS system, the renin-angiotensin system, seems to play a major role in the establishment and maintenance of LVH. It's not only the activated systemic renin-angiotensin system, but also the intracardiac angiotensin system appears to be involved in this mechanism of developing LVH. This intracardiac angiotensin system plays a role in long-term regulation of the structure of the heart, and when activated, it promotes myocardial hypertrophy and interstitial fibrosis, which might contribute to the functional and prognostic impact of LVH. This major trial, which was published in the early 2000s, it actually studied the use of losartan in comparison to use of atenolol beta blocker in hypertensive patients, assessing the cardiovascular morbidity and mortality. This is the live trial, and we all know that losartan was the leading ARB, leading developed angiotensin receptor blocker. In this large trial, the primary endpoint was the composite of death, myocardial infarction, or stroke. The secondary endpoints were changed in systolic and diastolic blood pressure. Individual endpoints in composite, which is death, MI, or stroke, were also studied. Angina pectoris, heart failure requiring admission to hospital, coronary or peripheral revascularization procedures, resuscitated cardiac arrest, and new onset diabetes were also assessed. So what were the outcomes? I will quickly run through the outcomes from this major trial. Blood pressure actually fell by about 30 figures in the losartan arm and 29.1 in the atenolol arm, comparable in both arms. The primary composite endpoints, however, occurred in 11% of the losartan treated patients and 13% of atenolol treated patients. So this here outcome here is more in favor of the group which used losartan. Cardiovascular mortality was 4% in the losartan group and 5% in the atenolol arm, and stroke was lower in the losartan group as well. New onset of diabetes occurred less frequently in the losartan arm. So all in all, the outcomes were more in favor of losartan compared to the use of atenolol. In the live study, it was associated with a significant reduction in cardiovascular events, stroke, cardiovascular mortality, newly diagnosed diabetes, paroxysmal atrial fibrillation compared to the atenolol arm. However, the reduction in blood pressure, as we've seen in the previous slide, was comparable, 30, 29, around reduction of about 30 figures. In the live study, LVH regression, which was diagnosed by ECG utilizing the Sokolov line index or the Cornell product criteria, the LVH regression in response to losartan improved clinical cardiovascular outcomes independent of the blood pressure reduction. As you have seen now, both groups had similar reduction in systolic blood pressure, but the outcome in terms of the regression of LVH was more in favor of the losartan. So it's not just about the blood pressure reduction. As you can see here, the reduction was similar in both groups. No difference in the reduction in the blood pressure, but the outcome was different. Why was that? The possible explanation for this was in the losartan arm, maybe there was more significant reduction in the ECG and echo signs of LVH, which decreased the rate of paroxysmal atrial fibrillation. And there was decreased carotid artery wall thickness. It was improved. The losartan improved the elastic properties of the arterial walls. It also decreased the hypertrophy in resistant vessels, and it improved endothelial function and inhibited platelet aggregation, and it also resulted in reduction in serum uric levels. And possible mechanisms were hypothesized to be through the intracardiac angiotensin system we just mentioned in the previous slides. So treating hypertension has a major impact on reducing the risk of incident heart failure, excuse me, and heart failure hospitalization, especially in old and very old patients. This has been observed using diuretics, beta blockers, ACE inhibitors, or ARBs, or calcium channel blockers. The calcium channel blockers being less effective in comparative trials. So reducing blood pressure can also lead to regression of LVH, which has been shown to be accompanied by a reduction of cardiovascular events and mortality. The magnitude of LVH regression is associated with baseline LV mass and duration of therapy, the systolic blood pressure reduction, and the drugs used with ARBs, ACE inhibitors, and calcium channel blockers causing more effective LVH regression than the beta blockers or the diuretics in their own merit. So I'll stop here, and I hope that I share this case, which we commonly see in our practice, showing you the evidence that in this similar case, that the use of an ARB such as the losartan with a thiazide diuretic will give us lots of benefit in terms of powerful reduction in blood pressure, reduction or improvement or regression in LVH, reducing the cardiovascular risk and the risk of stroke and possibly risk of mortality as well. Thank you.
Thank you so much, Dr. Ahmed, for this very informative and interactive case. I think it was really, an enjoyable experience for everyone to be engaged in such an illustrative case. So now we'll move to the second case, and Dr. Amin Al-Jayousi. Dr. Amin will talk to us about another hypertensive and diabetic with nephropathy case presentation. So, Dr. Amin, the floor is yours.
Thank you, Michael. I am trying to share my... Can you see the slides?
Yes.
Thank you. I will just put it in presentation form. Assalamu alaikum. Good evening, dear ladies and gentlemen, dear colleagues. First of all, I would like to thank you for joining us. Thanks for Organon giving me the chance to share with you one case of our patient, and thanks for the organizing committee of OSCAR meeting. My talk will be about paradigm in management of hypertension with single pill combination in a patient from our clinic. Then I'll be talking about the magnitude of the problem of hypertension and management of patients with such cases like diabetes, hypertension, kidney disease. Then we'll move to universal blood pressure staging, the power of a single pill combination, benefit, and the treating the blood pressure, how low to go. You know, there is a lot of discrepancies and a lot of thoughts about it, and some of the slides have been projected by my dear colleagues who presented before. Now, this is our patient, Mrs. Mariam. She is uncontrolled type 2 diabetes patient, and she is hypertensive. Mariam is 68 years old, and she got diabetes type 2 for the last 15 years. Her blood pressure is high at a level of 160/92. Her body weight 86.6 kilos, and her BMI, she is on the obese side, 32 kilogram per meter square. Her heart rate is normal, and her ECG voltage criteria is normal. Now, Mariam is diabetic. Her hemoglobin A1C is 8.9%, which is uncontrolled. Her fasting blood sugar is little high, 148, and her urine showed 24 hours urine glucosuria. Now, her current medication, she is receiving cholesterol treatment, rosuvastatin, 20 milligram, diabetic medications, sulfonylurea, DDP4 inhibitors, fixed dose combination, and amlodipine for her blood pressure as a dose of 5 milligram. Now, one question might be asked: should we screen Mrs. Mariam for her kidney functions? She is diabetic, she is hypertensive, and longer duration of diabetes, as well as she is having high cholesterol. For sure, we have to, because 30 to 40% of our patients with diabetes, they end up with chronic kidney disease. And when we check her EGFR, the two factors that we are following to check for chronic kidney disease, she got EGFR of 55 ml per minute per 1.73 meters square, and her urine albumin creatinine ratio is high at a level of proteinuria 320 milligram. So we'll come back to our case, Mariam, after this discussion. Hypertension remains the most common risk factor for cardiovascular morbidity and mortality. Its incidence is rising in both aging and obese populations. Its control remains inadequate worldwide. and less than a third of individuals with usual blood pressure exceed 140/90. Most of the time, the blood pressure is inadequately treated. Now, the prevalence of hypertension by age and gender, as you see, men are more than women prevalence of hypertension till the age of 60. And after the age of 60, at around 70 years of age, women become more prevalent with hypertension. Now, the modifiable risk factors are leading to the cardiovascular death. The highest, as we see, is hypertension. That will lead both in developing countries and developed countries. And then we will show that the global impact of elevated blood pressure is increasing, having a study of about, in 2015, blood pressure was the leading global contributor to preventable death. And as you see, patients who are aware about blood pressure, only 46%, those who are treated only 40%, and those who are controlled only 1/3. Now, hypertension and increased cardiovascular risk, there are associations between the higher systolic blood pressure and the diastolic blood pressure leading to cardiovascular disease, and this was mentioned by my previous speaker. If we have 20 millimeter higher systolic and 10 millimeter higher diastolic, it will lead to double risk of heart disease, stroke, as well as vascular disease. Now, one should be careful in the old age. Above the 65 years of age, there will be increased risk more than the younger ones. Now, what about if we reduce 5 millimeter mercury of systolic blood pressure? We will gain a lot. We will reduce the stroke mortality by 14%, coronary heart disease by 9% mortality, and all-cause mortality by 7%. What about if we reduce only 2 millimeter systolic blood pressure? We will gain a lot. We will reduce the stroke mortality by 10% and the ischemic heart disease mortality by 7%. What about 10 millimeter of mercury? If we reduce, we will gain a lot. We will have reduction of about 20% MACE, 28% heart failure, 27% stroke, 17% coronary heart disease, and all-cause death or mortality by 13%. You see, we gain a lot if we reduce the blood pressure by 10 millimeter systolic. Now, what about the prevalence of controlled blood pressure over time? Most of the time, the blood pressure control will be decreasing. And this is from the National Health and Nutrition Examination Survey. As you see, over time, between 1999 and 2017, there will be a drop and decrease in the controlling blood pressure. And even those who are on antihypertensive treatment, over the time, it will be decreased and poorly controlled. What are the predictors? Why we have problem with poor control of blood pressure? There are different factors, as mentioned by my previous speakers. Could be the health system, the primary health care, the low adherence of the patients to medications, the unhealthy lifestyle. You know, they are eating a lot. Obesity will be leading to hypertension as well. The competing priorities. Patients are having polypharmacy, and they are engaged by so many things other than the blood pressure treatment. The clinical inertia by the physicians that keep, postponing the management of hypertension and not being active by following the blood pressure. And long appointments with the healthcare system, about 6 months, maybe 1 year. Now, what about the blood pressure? We have problems with the blood pressure at the office because we have almost 17 to 20% white coat hypertension. Patients, when they come for their appointment in the hospital, they will become scary and they will have high blood pressure, and this is not genuine. Now, one should take 2 to 3 office visits at 1 to 4 week intervals to check the blood pressure, to take the average. And whenever possible, the diagnosis should not be made on one single visit. And always, one should confirm it. And when we take it, we have to have the nurse sitting the patient, having his back supported or her back, and then not talking. Patients should be relaxed, and we should have the proper cuff for the arm to fit it, and should have the cuff at the same level of the heart. You know, all these things very important too, and they will make a different measurement for blood pressure. Now, whenever possible, one should do the home blood pressure monitoring and or even the ambulatory 24 hours blood pressure. Now, the hypertension definition and classification have been put forward by different societies, international societies, European, American, as well as International Society of Hypertension. And as you see, they defined the normal 120 to 129 as systolic over 80 to 84 by the ESC, ESH. While the Americans, they mention it as less than 120 over 80. If you take this grade 1 hypertension, for the Europeans, they are a little bit soft, not like Americans. They make the grade 1 hypertension as only 130 over 139 systolic over 80 to 89 diastolic, while the Europeans mentioning it as 140 to 159 systolic over 90 to 99 diastolic. The International Society of Hypertension, more or less the same like the ESC, ESH. And grade 3 hypertension, anything above 180. Now, what about lifestyle? Lifestyle advice is very important for patients with hypertension because this will help to reduce the weight as well as to reduce the blood pressure, and initiation of this will be at the same time that you see the patient and confirm the blood pressure diagnosis or hypertension diagnosis. And it should be given for all those at high normal or grade 1 or grade 2 or grade 3 hypertension. And one should not leave the patient to be checked within more than 3 months. 3 months should be enough for control and to be observed. Now, the guidelines in 2018 put forward by ESC, ESH, they mentioned that combination treatment is recommended for most hypertensive patients as initial therapy. And what they prefer as combination, the ACE or ARB with a calcium channel blocker or diuretic. Other combinations of the other 5 major classes can be used. The same WHO put 2021 guidelines in adults. They mention combination therapy is preferable because at the start, because it is helping for the avoidance of the clinical inertia. Why the latest evidence pushing us or guidelines to use single pill? Because it improved the adherence, it simplified the treatment approach, it improved the persistence of medication, and improved the blood pressure control. Now, the core drug treatment strategy for uncomplicated hypertension, this is put forward by the ADA as a single pill, initial therapy, dual combination, ACE or ARB plus calcium channel blocker or diuretic. If not controlled, we move to step 2, which is a triple combination in a single pill, which is ACE or ARB plus calcium channel plus diuretic. For resistant hypertension, we use the triple combination plus spironolactone or other drugs. What about beta blockers? Beta blockers can be used at any stage or step, especially if there is specific indication for their use as heart failure, angina, post-MI, atrial fibrillation, or younger women with who is planning for pregnancy. This showed the different combination between different classes among antihypertensive drugs. As you see, the green lines, continuous lines, showed that we can combine thiazide diuretic with angiotensin receptor blockers, or thiazide with calcium antagonist, or thiazide with ACE. But we don't combine ACE with ARB. This is not recommended. And possible, we can use thiazide with beta blockers. Now, the combination therapy superiority to sequential monotherapy. It's much, much better. And this study or trial showed that those who are receiving or received the combination therapy of losartan plus hydrochlorothiazide were much better, improved, and controlled about 74% when they have been given and compared to those who are taking the drug on its own as monotherapy, whether hydrochlorothiazide or losartan. Now, there is an increased chance of blood pressure control over 1 year by initial combination therapy versus monotherapy. If you see here, the control of blood pressure is neutral with the monotherapy. Free combination using each tablet alone, 2 tablets, each tablet alone, is much less effective in blood pressure control when compared to the single pill combination. This is very much better to control the blood pressure. So single pill combination is better than free combination, better than monotherapy. Now, the risk of cardiovascular events in patients on initial fixed dose combination or monotherapy, which is better? For sure, the fixed dose combination showed that there is, you see, for the monotherapy, it's neutral. It will not improve or prevent or reduce the risk of cardiovascular events. But when you compare it to the combination therapy, whatever, there will be risk reduction of cardiovascular events, heart failure, cerebrovascular disease, ischemic heart disease, and death, all in favor of the medicine of combination. Now, what is the benefit of combination? Like losartan with thiazide, with hydrochlorothiazide. Thiazide is a diuretic leading to natriuresis volume depletion. And the losartan, which is ARB, that will lead to vasodilation and sodium volume reduction, both of which will lead to lowering blood pressure. Now, one question for how low should we go for blood pressure? Now, in the GNC8, the 8th Joint National Committee in 2014 mentioned a recommendation that in general population age 60 years, initiate pharmacologic treatment to lower blood pressure as systolic 150 and diastolic 90, and to reduce the blood pressure below these levels. In 2018, the ESC/ESH guidelines showed that first objective of treatment is to reduce or lower blood pressure less than 140/90. For those who are 65 years or less, systolic blood pressure to be 120 to 129. And for those older, more than 65, the blood pressure to be less targeted to a level of 130/139. Now, here are the blood pressure targets in international guidelines, and this is based on office blood pressure. Now, as you see, the ACC/AHA and the ESC/ESH. I follow these, the American guidelines and the European ones. When we have no comorbidity, both of them, they mentioned that it should be 130/80 for managing targeting blood pressure. The older patients, for the ACC/AHA, the American, 130/80, while the European, 140 to less than 140/90. What about the diabetic patients? Diabetic patients both agreed that should be less than 130/80, and for the chronic kidney disease, 130/80 for the Americans and less than 140/90 for the European. As you see, Europeans are a little bit less stringent for controlling blood pressure, but Americans are very tight. Now, coming back to our patient, Miriam. Miriam is having chronic kidney disease. She is diabetic, hypertensive, hyperlipidemic. And this is a question. What is the provisional diagnosis of this patient? I'm not expecting an answer from you. I just want to mention that this patient is having hypertension. She is having type 2 diabetes, and she is having nephropathy because of the microalbuminuria, proteinuria, as well as the reduced eGFR. Now, how many risk factors in addition to her hypertension she is having? 1, 2, 3, or more than 3? This patient is having more than 3. She is having diabetes, hypertension, lipids, she is obese, all these. Now, what's the level of the cardiovascular risk for this patient? Is she high level of risk for cardiovascular or low, moderate, or very high? I think this patient, we categorize her with being diabetic plus more than 3 risk factors. She is very high risk. And this is the cardiovascular risk factors when we are considering them through the ESH, European Society of Hypertension. Those who are having the age in males 55, in females 65 years and more, and our patient Mariam is 68 years. Diabetes, she is diabetic. Established cardiovascular disease, she is not. Elevated LDL, she is, microalbuminuria, she got proteinuria, she is obese, her BMI was 32. And for those who are smokers, a risk factor. So our patient, Mariam, she is having more than 3 risk factors and being diabetic as well. So she is at, Mariam, according to the cardiorenal complications, should be considered as very high risk patient. And this is the criteria for very high risk patients. Patients with diabetes and established cardiovascular disease, she is not, but there is target organ damage as well as more than 3 major risk factors. Early onset type 1 diabetes for other patients with more than 20 years duration of diabetes type 1. Now, this is the stratification for cardiovascular risk by ESC, ESH, and here our patient, she is very high risk, having diabetes plus other risk factors, and her blood pressure was 160 over 92. What goal of management for this patient? Being diabetic, having albuminuria, nephropathy, and hypertensive, as well as hyperlipidemic, I think I would go for a lifestyle modification, as we mentioned, for all patients with hypertension. Her blood pressure should be less than 130 over 80, and we have to reduce her albuminuria. And one of the major medicines used and have been approved for the treatment of albuminuria is the ARBs. And the systolic blood pressure for all patients have been forwarded by ESC and ESH in 2013. The systolic blood pressure should be less than 140 for the following categories: for diabetics, for stroke or TIA, for patients with coronary heart disease, for diabetics without or with chronic kidney disease or without chronic kidney disease, and one should be careful for old age, not to be that too much strict. For those who are very elderly, for example, 8 years, one should be considering it less than 140, but according to the tolerability of the patient. Now, the diastolic, one should get it less than 85. This, our patient recommended the therapy for her, having RAS or beta blockers plus a diuretic, or calcium channel blocker, or ARB plus diuretic. We mentioned that ARB and diuretic, both losartan and hydrochlorothiazide, could be much better for her to treat her hypertension, to reduce her proteinuria, and to reduce her cardiovascular risk. This recommendation has been put forward by the ADA, where they mentioned that in their guidelines, patients with diabetes and hypertension either ACE or angiotensin II receptor blocker. If one class is not tolerant, the other should be used. Also, multiple therapies from the start, and to administer one or more antihypertensive medications at what time? At bedtime. Now, I myself would advise my patient to use the medicine in the morning if there is a diuretic with it, but usually other medicines at bedtime. This is the drugs that are preferred in specific conditions. For example, those with left ventricular hypertrophy, as mentioned by my colleague, Dr. Ahmed Al-Sadiq, ARB was the treatment. Those with microalbuminuria are ARB, renal dysfunction as our patient, ARB. Also for those with end-stage renal disease, proteinuria, like Mariam case, all diabetic patients, ARB is a treatment. Now, what is the support or clinical trial that mentioned in the science? We have the trial which is named RENAL. RENAL is a study where they included 1,513 patients with type 2 diabetes and nephropathy, like our patient Mariam. And this study was prospective, double-blind, randomized, placebo-controlled study comparing what? The effect of losartan with chlorothiazide versus placebo plus chlorothiazide. They want to show how much of losartan helpful and beneficial for patients who are having renal complications, like our patient Mariam. And the duration of the study was 3.4 years and 250 study sites in 28 countries. This is a huge study. And the patients, the primary endpoint was 686 patients to reach the primary endpoint, which is the doubling of serum creatinine, end-stage renal disease, and death. And what were the results? 16% relative risk reduction in favor of losartan compared to the placebo arm, and it was significant. What about the end-stage renal disease? 28% relative risk reduction, and it was significant in favor of losartan. Also, the effects of losartan on renal and cardiovascular outcomes in type 2 diabetes and nephropathy, 28% risk reduction. What about the first hospitalization for heart failure? In favor of losartan, 32% relative risk reduction, and it was significant. The change from baseline for proteinuria, it was in favor of losartan, about 35% relative risk reduction, and when compared to the placebo. But by this and the results of RENAL, the FDA approved COSAR as an indication for treatment of renal disease in adult patients with hypertension and type 2 diabetes, with the proteinuria more than or equal 0.5 gram per day, as part of an antihypertensive treatment. What other benefits that we have for losartan? Losartan, when compared with candesartan, as well as losartan, these are the same agents in the same group, ARB agents. ARB blocker agents, and they found that the uric acid will be increased in cases of people or patients having candesartan and valsartan as well, to a lesser extent. So losartan showed benefit as well as for uric acid reduction. Now, in summary, I hope I am not late for you because it is at the end of the studies and conference. Poor controlled hypertension is a common problem throughout the world, and current guidelines note that the combination is necessary to achieve target. Don't forget combination single pill therapy, losartan plus a diuretic hydrochlorothiazide, which is named as HAZAR. First in a class powerful protection, about 25 years of clinical experience worldwide. Honestly, we have been using it for years and years, and it showed good benefits. It reduces the blood pressure about 30.4 systolic. It's very powerful. 28% reduced the risk of renal disease by the RENAL study that we mentioned. 25% reduced cardiovascular morbidity and mortality in the LIFE study in patients with hypertension and left ventricular hypertrophy mentioned by my colleague Dr. Ahmed Sadiq, and 32% reduction for first hospitalization for heart failure, as well as reduction of uric acid and with powerful blood pressure reduction. By this, I think we end. Thank you for listening, and I'm waiting your questions.
Thank you so much, Dr. Amin, for this very interesting and informative presentation. And I see that there are lots of positive interactions on the chat. I think we have a couple of questions that I will direct to each one of you separately. So I will start with Dr. Ahmed. Dr. Ahmed, there is a question saying, at what age you recommend screening for hypertension?
Generally, you'll have to look into the risk factors mentioned by my colleague now. If the patient has any of these risk factors, I think we should be proactive in screening, regardless of the age. But in general population, maybe most of the recommendations is around the age of 40 would be reasonable age. But if there's a risk factor, regardless of the age.
Okay, thank you so much. So, Dr. Amin, the second question is saying, grade 1 hypertension or mild hypertension without comorbidities, when to start the treatment and the blood pressure charting rule?
Usually we have to confirm the blood pressure diagnosis. You know, I myself used to take my blood pressure at my home. The first reading, second reading even, it will be abnormal. But when you get it as relaxed at your home, especially at bedtime, this will give you a better and very good reading. Usually, those patients whom we find that the blood pressure is not controlled different times, we feel that they are, you know, not psychic but anxious. We may use the home blood pressure monitoring, the 24 hours ambulatory blood pressure machine, and try to take the average blood pressure. Too many fold blood pressure readings may be just because coming to the hospital. You know, many patients, they are psychic and they say, well, no, I don't want to take the blood pressure. And I say, no problem. Do you have a machine at home? You can do it and just make sure that to take 2 or 3 readings. If you confirm the blood pressure, you will start with the treatment early. One thing I want to stress hard here, that medicines are not everything. The lifestyle is very important. So many patients, we reduce their blood pressure by reducing their weight. Obesity is a confounding factor, and here, you know, obesity is very common. Here in Qatar, obesity is almost 35% in general, and in females more than 70%. So one should be careful before, you know, this tablet of medicine. A common question they are asking me, patients, am I going to continue for life on this medicine? I will say, if you can control your blood pressure without it, okay, we can stop it at any time. Just try to reduce your weight, start the medicine, let's control the blood pressure and observe. And if you need it, we continue. If you don't need it, we will take it off. So it depends upon the case. We should be careful to look for the cause of the blood pressure as well. Maybe it's only anxiety. So many patients saying, oh, when I get upset at work or at home, I will get my blood pressure very high. And other times it's very normal. One should confirm the diagnosis. Always I'm saying diagnosis, and diagnosis.
Yes. So thank you so much, Dr. Ahmed. The last question coming to you. Which antihypertensives can be used safely in chronic kidney disease patients?
I think we've just seen now, for example, the agents of ARBs, particularly losartan. It has safety data in chronic kidney disease at different stages. So that will be a reasonable choice, I think. There are some safety data also for other groups, such as some ACE inhibitors, and for other groups, channel calcium channel blockers as well. But if we are talking specifically about possible choice, maybe ARBs will possibly be, I think, a reasonable option, because we've seen the evidence that they target the cardiovascular and cerebrovascular risks, and they reduce these risks. So it's not just about the safety issue. Safety is very important in terms of the renal function, but we'll also look into the whole picture, improving in the other outcomes as well.
Okay. Thank you so much, Dr. Ahmed. Thank you so much, Dr. Amin. And this brings us to the end of our session today. We had two very interactive and live cases from Dr. Ahmed Sadiq and Dr. Amin Jayousi about different profiles of hypertensive patients. And we hope that the whole day has provided you some useful information about the management of dyslipidemia and hypertension. So on behalf of myself and the whole Organon team, we'd like to thank Dr. Ahmed and Dr. Amin and the whole speakers and moderators who were involved with us today. And we want to thank you for your presence and your active participation as online audience. And by this, we conclude the first day of the Oscar Congress, and we will stay tuned for the second day tomorrow, in which we will address topics related to bone and pain, biosimilars, and fertility and others. So stay tuned for the second day of the Oscar Congress. And again, we extend our warm gratitude to Dr. Ahmed and Dr. Amin for their participation with us today. And we hope to see you again in future events. So thank you so much, dear professors. Thank you so much to the online audience, and have a good rest of the day, everyone.
Thank you, Dr. Sadiq, and thanks for Organon and for everyone who joined us. Thank you.
Thank you so much, sir. Thank you. Have a good day.
Thank you.